Thank you, Raj, and thank you, Goran, for the introduction and for the invitation. And now I switch to my presentation. I hope you can see my slides.
We see.
And you can hear me. Okay.
Perfect.
So that's my disclosure. So what are the special features of left main? So we all know that this is a very large and short vessel. If there is a lesion, bifurcation is often involved. The side branch here, the circumflex artery, is the largest side branch we have in our coronary system. The angle is often wide, and we see very often calcifications. So as for the caliber of the left main, so by computed tomography, you see that for male is around 4, a little bit more than 4. In female, left main is a little bit smaller. But in Yves, and this is has to be stressed as this is a Dutch population, and Dutch are the tallest citizen of Europe, and only male patients. So you can see that the average left main diameter was 5.6, and only 13% of them had a diameter smaller than 5 millimeter. And also the distal DB angle of bifurcation, which is the angle between LAD and circumflex artery, is close to the right angle. It's around 80. Whereas for the other bifurcation is more narrow, like 50. So when you look at this anatomy, this is a histology of the left main. So what is specific for this anatomy? So you see the bifurcation of the left main is involved, but the carina is free from disease. So this is a common feature of the majority of bifurcation, not only for the left main, of course. But also what you can appreciate here is the diffuseness of the disease, and actually the plaque extends both directions towards the LAD, but also towards the ostium of the left main. And given the size of the vessel, and geographically, it may be really very difficult to assess the extent of the plaque towards the ostium and the left main. And of course, the presence of calcium is also very important. So given this anatomy, intravascular imaging is strongly recommended, as well as aggressive preparation before stent implantation. But also this image shows that single stent procedure should work in most of the time. Another issue very specific to left main is the problem with diagnosis if there's an osteal lesion. So you can see the two images. In one, which is typical, the tip of the catheter engages too deeply, so the ostium is missed actually. And on the second, on the right-hand side, you can see that really there is a very tight calcified ostium in the left main. So angiographically, it's very easy to overlook this kind of lesion. Another important characteristic of anatomy is the ostium of the left main, and due to because the edges of the ostium are not parallel, it's not possible to cover the ostium without a stent protrusion. So if you want to cover properly the ostium, you will have some protrusion of the stent towards inside the aortic sinus, and this, of course, bears some potential risks. One of which is possibility of abdominal stent rewiring, because your guide may be pointing beyond the stent strut. So this is also very important to keep in mind. As we all know, these are data from both Excel and Nobel studies. Majority of lesions are bifurcation lesions. So all the rules for bifurcation stenting applies also to left main. So we, in respect of fractal geometry of this anatomy, we should not choose the stent size according to proximal reference, because then we will compromise the flow towards the side branch. Instead, we should choose distal reference, which is LAD in this example, leaving a gap in a left main, which should be corrected by proper pots. What is specific for the left main, if we now apply the Murray law to respect this fractal geometry, you have to keep in mind that due to the size of all the vessels, the difference in the sizes will be quite large. So you can see if you have a circumflex artery of 3 and proximal LAD of 3.5, if you calculate what should be diameter of left main is not 4 but it's almost 4.5. And this, of course, have some other consequences, because you should properly size your stent and you should know what are the expansion limits of your stent. This is an example when the borderline between one size and one design and another design, this is Promus stent is between 275 and 30, not 2.5, for example, and you should know this, because 2.5 and 275 is the same stent. And if you choose too small a stent for given anatomy, you will end up with some stent damage, or you may lose integrity of the struts. So this is very important to know what stents you are using. And if you look into one of the Euro Bifurcation Club position paper, in your intervention 2018, you will find what are the expansion limits of mostly used stents now in Europe and in America as well. So for left main, stenting size really matters. Yeah, this is another consequence of stenting left main. So you have a situation when the circumflex wire is jailed after main vessel LAD stenting. And you should keep in mind that as long as this wire is jailed, your guide will never point in towards the lumen of the stent. It will always point at the edge of the stent. So of course, this phenomenon has certain consequences. The one is that you can very easily go abluminally with your wire. So before you rewire circumflex artery, do the pot first with a jail wire in a position, then you'll be able to enter intraluminally into the circ. Another very important consequence of this close proximity between guiding catheter and the stent is the risk of longitudinal stent deformation, which is very common in a left main. So this is one of the examples. It's very difficult to recognize this angiographically. So this is the final result on the left-hand side of left main stenting. In the caudal view, it looks perfect, but when you look at the cranial view, then you see something. And then if you don't use intravascular imaging, please use at least this any stent enhancement imaging, and you will clearly see that the stent is partially damaged, partially crushed by the tip of the guiding catheter. Of course, the best thing to use is intravascular imaging. Here you see a very nice presentation by OCT, when you clearly see how the stent is distorted and the proximal part of the vessel is dissected. But you'll hear more about intravascular imaging on the next presentation. So it occurs mostly when you are trying to pull back some bulky device from the left main, like a Potts balloon, for example, or when you are pulling back a jailed wire. This is not a benign complication. It occurs in roughly 6 to 7% of cases. These are data from Excel study when only very experienced centers took part. And you can clearly see that after 3 years, the risk of MACE is significantly higher if there was some stent deformation. And actually what they found was that stent deformation was the independent predictor of MACE in the 3-year observation. So how to avoid this? So that's one of my way to do is disengagement of the guide before pulling back the large bulky catheter or unjailing the wire. So you see that the guide is now pulled back into the aorta. Another way is just to drop one more wire into the aortic ostium, and then you can stay away with your guide from the edge of the stent. So to summarize, Left main is a short and a very large vessel, which requires a stent with a broad expansion limits. Stent protrusion into the aorta is very common, and this bears the risk of abdominal rewiring. Direct contact of the guide with a stent bears the risk of stent deformation, so keep it in mind. And that's why intravascular imaging is highly recommended. Thank you very much for your attention.
That was fantastic, Dr. Lesiak. A very insightful presentation. I'll open it up for any comments from other panel members.
Raj, I thought it was great. One of the things I liked was the description of sort of the sizing, because I don't think people always think about that.
Yeah, the knowledge of the stent expansion limits is really not very widely spread among interventional cardiologists, and we should really know what stent we are using for this anatomy, because sometimes the difference between the LAD or CIRC and the left main is really huge, and not any stent, not every stent can allow for this overexpansion. So this is, I think, something that we should all realize.
Vlad, you were speaking, but your mic was off.
Yes. It's not unusual that you'll have a left main that's close to 6 millimeters, and there are very few stents that can actually go that high. So I agree, that's very important that people understand their platforms and that they use appropriate platforms, especially for the left main.
There is a question from the audience. Should all left main stenting cover aorto-osteal junction?
No, I don't think so. The first thing is to know what is the plaque, whether we have a very diffuse plaque. So the best way is to use intravascular imaging. If there is no much plaque at the ostium, I would not recommend to cover it, because when you cover the ostium, you will always increase the risk of deformation. But if you are not using the intravascular imaging, then you can use the Finite principle and calculate, and then perhaps you may find whether the ostium is involved or not. And of course, if the left main is very short, it's difficult to not to cover the ostium. So if the left main is less than 5 millimeters, in most of cases you will cover the ostium as well.
I think that's a great comment. What I would add to that is that you need to give yourself enough length to do a proper pod procedure. So whatever the length of your pod balloon, 8 millimeters usually, or sometimes I think 6 is available, but you need to have at least that length of stenting in the left main so that you can optimize your stent result.
One more question from the audience. Do you remove your jailed wire before or after pot?
No, always after pot. So because otherwise, when you rewire, there are two issues. One, when you rewire before pot, you are very high risk of getting your wire under the struts of the stent. The second thing is that any manipulation with a guiding catheter when the stent is not properly expanded increases the risk of the damage. So first spot with a jailed wire, don't hesitate, don't be afraid. 4.5 balloon is just the my diameter of choice, but if needed, you can go 5.0 or 5.5, even 5.5. With a jailed wire. Majority of current wires are very resistant, and there's no really very low risk of wire damage.
One more question from the audience is about the use of something called an Osteal Pro flash balloon, which pushes the osteal part of the stent against the wall. Anyone has experience in using that device for left main ostium? And if not, can you use a big balloon, like a 5.0 balloon, to do it?
Yes, good question. We have got, this is Sudhir here. Greetings to all of you guys. And we have got some use of using Osteal Pro. It's a device which you deploy at the aorto-ostial junction when you do the procedure. And it basically, what it does is it avoids too much of overhang of stent into the aorta, rather than, so it allows you to cover the ostium with confidence. And there are a few other techniques you can use. You can put a wire in the aorta outside the guide catheter, so that will give you some guidance. It's a good comment. And obviously we try to cover the ostium, because if you miss the ostium, you might have some balloon injury, which might cause problem later on. So that's my comment. So we have used in few cases. It's a bulky device. You have to sometimes use the 7 French guide catheter, and you have to place the device at the ostium, and it flares outside. And then you pull your stent before deployment, so it stops just at the aorto-ostial junction, and then you deploy it. So it allows, so it's more sort of, so that you don't protrude the stent too much into the aorta, and not too much of overhang, and only 1 or 2 struts overhang, and then you flare it up with a bigger balloon.
Well, thank you very much. I think that in the interest of the time, there's quite a few other questions. I'm going to try to answer some of them online. Or any other faculty can also look at some of the questions at the bottom of your screen in the Q&A section, and you feel free to answer them. But for the interest of time, you have to keep moving. And now it's a privilege to introduce Dr. George Vetrovec, who is a Professor Emeritus at VCU University and in Richmond, Virginia, also a course co-director for C3 meeting and a previous award winner of C3 Lifetime Career Achievement Award. So he's going to discuss the fundamental question of PCI versus CABG for left main disease. What is the latest in the evidence-based approach?
Thank you very much. It's a pleasure to be here. Thanks, Raj. We'll move on and hopefully have a very good and quick discussion of a pretty complex and somewhat volatile topic. These are my disclosures. I think everyone's going to talk about specific technical things, but I call this technical considerations on a more global level. And the first one in making all these decisions, and we'll try to cover this, is PCI the best option? Is complete revascularization possible? Is the coronary anatomy amenable relative to complexity calcification? What about patient comorbidities? And one thing that people don't like to talk about, but is the facilitator, the facility or the operators, do they have the resources and the experience to make this really happen? And then the other side of this is the patient a good candidate for CABG? They may not be. Things like renal status come into all of this. And then what is the projected outcome versus the realistic expectation by the patient, by everyone? So there are a lot of things to really think about. Now, the contemporary use and trends of unprotected left main was looked at in the NCDR registry, and that actually shows a relatively low use of PCI for left main. In that registry, it represented about 1.5% of the patients in the registry. So it's slowly going up over the years. This was to 2015-16, but it's not overwhelming. And the concerning part of this is in that registry, which is an all-comers registry, all of the categories of activity were really related to, were all worse for the unprotected left main compared to all other PCI. So stroke, emergent CABG, all of these things, death, biomarker positive. These are all acute results. So something to really think about in terms of that. It was about a 3 times greater risk, and only MCS was used in about a quarter of the cases. And their conclusion was as unprotected PCI of the left main had increased, but overall the use was low. And I thought this was interesting. I did a poll on the acc.org, which on the interventional section fairly recently, and asked what's the percentage of patients with significant obstructive left main disease? Can you consider do you consider CABG to be optimal? These are small numbers of respondents, but based on the NCDR, probably the way people think. 75% said CABG was the best treatment in 75% of the cases. 32% said 50%. And then when you ask what were the issues, a big part of it was overall better results, but there was also a lot of discomfort with doing it. So there are these skill and experience level issues. Now hit the big trials, and this is where a lot of controversy comes. This is the XL trial. These are the 5-year results. And what you see here, if you look at death, stroke, or myocardial infarction, which was a composite endpoint, and all of these studies tend to use composite endpoints because in reality, the event rates are low. And what you see is that the composite endpoint ultimately was nil, being slightly worse for CABG initially and better late with a crossing of the lines. If you look at the composite endpoint and include revascularization, then bypass surgery wins, and that's statistically significant. But if you look at the other factors here, not statistically significant. If you look at breakdown of each of these individual risk, you see that different cause, PCI was higher, but not statistically significant. If you look at stroke, you can see that CABG overall in this study was higher the whole time, but again, not statistically significant. If you look at myocardial infarction, again, PCI late is worse, early is worse. And then for bypass surgery. And then if you look at ischemia-driven, PCI loses that always with a higher risk, and that's a significant difference. If you look at the sub-analysis of various things, the syntax score always comes up as an important one. And you see here the syntax score by levels tends to trend toward the higher the score, CABG better, but this is not statistically significant. Now, in contrast, the XL trial was randomized, was a European trial, and this is the composite data, the stable ischemic, stable ischemic disease. This is the 3-year results showing that there was no difference in outcome for acute coronary syndrome or stable ischemic disease. So this is an important point. The stability of the patient didn't seem to make a difference. So the final conclusion at 5 years was in patients with left main disease of low or intermediate anatomic complexity. There was no significant difference between PCI and bypass surgery with respect to the rate of the composite of death, stroke, myocardial infarction at 5 years. We'll come back to the challenges to that. The NOBLE trial, on the other hand, has been reevaluated at 5 years as well. And this shows somewhat different results. MACE continues to separate, favoring bypass surgery over 5 years. All-cause mortality is not significantly different. Non-procedural myocardial infarction, significantly better for CABG or less with CABG compared to PCI and repeat revascularization. Obviously, as usual, favors surgery. If you look at stroke, it's sort of interesting. Surgery's a little higher initially, but late the bypass surgery patients have lower stroke and PCI higher. That did not reach statistical significance. Some primary outcomes of the subgroups: age 67, either sex, all weights, stable ischemic disease, distal left main, and a syntax score of less than 22, all statistically favored bypass surgery. If you look at the Kaplan-Meier estimates of the syntax score, you see low syntax score amazingly favored bypass surgery significantly, whereas there was no difference for intermediate and high. So in summary, in revascularization of left main coronary disease in the Noble trial, PCI was associated with an inferior clinical outcome at 5 years compared with CABG. Mortality was similar after the two procedures. Now the debate came when the surgeons raised concerns over the definition and incidence of PCI peri-procedure MI and whether the data was withheld because they didn't include all mortality, and also whether the definitions were changed. It's a complicated issue, but the study group have responded and have said there was no attempt, and everyone, including the surgeons, agreed. So I think this is one that's not totally answered to everyone's satisfaction, but it seems, at the moment at least, sort of a quiet disagreement. There are a lot of meta-analyses around, the most recent of which looked at 5-year results for syntax and Excel, 10-year results for, syntax, 10-year results, Noble and Excel, 5-year results, and pre-comment 5-year results, so forth. And what you see is this is a null result in terms of overall outcome. So I think this is probably a fair assessment. Several other studies have looked, and in general, the studies of meta-analyses show syntax scores lower, PCI is competitive, with all the same issues of stroke varying over time. This is another large, almost 5,000 patient studies, relatively lower mortality with CABG in patients with high syntax score. Both procedures resulted in similar long-term composite rates of death, myocardial infarction, or stroke, with PCI offering a safety advantage. And then this study by Goran and Wang et al. In conclusion, DES stenting with CABG for unprotected left main disease yield comparable rates of MACE at 1 year. However, CABG is associated with a decreased risk of long-term MACE compared with DES, exclusively driven by considerable reduction in revascularization events. So very consistent. I, of course, like this meta-analysis that I was a co-author on. These are the studies that were included in this. And the conclusions were, again, that patients with unprotected left main, PCI with DES yield similar all-cause cardiac mortalities compared with bypass surgery. Furthermore, CABG increases early within 30 days. MACE rates didn't increase risk of stroke. Overall, longer durations, PCI increases MACE, recurrent revascularization. So there are some miscellaneous issues, and I've listed them here, and we'll quickly step through those. If you look at quality of life, in general, what they show is that for quality of life, particularly related to physical limitations, surgery suffers early. They all have good angina relief early, but the physical issues of surgery cause that to be a little limited, but then it comes back. So the big difference in quality of life is early and recovering from surgery. The issue about kidney disease was looked at the 3-year results of Excel in patients with CKD undergoing revascularization for left main had increased rates of acute renal failure and reduced event-free survival. Acute renal failure occurred less frequently after PCI compared with CABG. There's no significant difference in PCI and CABG in terms of death, stroke, or MI at 3 years in patients with or without. And this shows the data. You see here the blue lines are the patients with CKD, the red lines with patients without CKD, dotted lines are CABG, and solid lines are PCI, and that just shows the relative higher, a little bit higher risk for PCI, but statistically there was not a difference. This is a touchy subject. This is operator volumes. which I touched on earlier. This is the BESIS database, some 6,700 patients, a UK study with patients undergoing left main PCI between 2012 and 2014. Operators performed somewhere between 1 and 54 cases per year. They divided this into quartiles. Quartile 1 was 2 cases, quartile 2, 5, quartile 3, 10, and quartile 4, 21. Higher volume operators did higher risk procedures with better outcomes. And if you compared quartile 4 to quartile 1, there was 59% lower MACE, 61% lower mortality. The optimal number was suggested to be 16 per year. Now, what's the potential value of hemodynamic support? There's a lot of questions about this, and I can't solve that, but I will show this data from PROTECT II. These were patients that were randomized with stable disease to have support with balloon pump or Impella. And in that, the subgroup that had left main, which is approximately 100 patients, about a quarter of the overall patients, there was a significant difference in terms of adverse events, although it was not statistically significant. So suggesting at least some degree of support may be important. And then, although it's written about in PCI in general a lot, it's a little harder to find in left main because there's so much focus on the left main per se. Long-term complete revascularization. This is an Italian study that used BESIS definitions for the extent of revascularization. It showed that improvements in LV function, most of these patients had LV function and about half of them had left main disease. Recovery of LV function was tied to better levels of complete revascularization, and likewise mortality was lowest in the patients who got the best revascularization, intermediate revascularization, and limited revascularization. So seems to be an important part of it. So I'm going to summarize the left main PCI versus CABG. Left main PCI remains low in all comers per the NCDR. There's an increased risk compared to all other PCI. 2 randomized trials, Excel and Nobel, excuse me, spelling, demonstrate discordant MACE results. Meta-analysis support equivalent mortality, but late revascularization supports CABG. There is some thought that the risk is greatest for PCI and the highest risk syntax scores. Stroke generally is higher early post-surgery, but some cath catch-up occurs. And MI risk is peri-procedural versus late, and this is a debate that's going on in all ischemic trials. Now, how does this impact cases? Well, Fajade in the European Heart Journal last year did a summary of sort of the pluses and minuses related to the procedure, to the follow-up, and then to the patient expected outcomes. And you can see that early the patients are happier with PCI, but later there's more issues with revascularization. So as I see it, the treatment decisions are patient-specific. The heart team review, patient discussion, recognize patient preference. Critical issues for PCI success include patient and anatomic risk for PCI versus CABG, potential for successful quality complete revascularization, is an important part of it. And institutional operator experience with complex PCI and hemodynamic support seems to be an important consideration in achieving the optimal results, both acute and then secondarily long-term. Thank you very much.
Thank you, George, for that very comprehensive, good discussion. We have two questions from the audience, and I think I'm going to open those questions up to the entire panel because those questions are for the panel. Is there any difference in the clinical outcome of PCI versus CABG between left main and multivessel disease with diffuse disease and left main and multivessel disease with focal disease?
I'll take it at the start. Generally, that hasn't been looked at as a specific endpoint. It's except beyond how that would be described by syntax score.
Well, actually, focal lesion, you need less stent, number of stent to have complete revascularization as compared to diffuse disease, long lesions, and so on. And of course, number of stents used for each patient does matter in the outcome because you have less MACE if you are using less stents in the same patient. So this can make the difference between focal and diffuse disease in these patients.
What is the best strategy for revascularization in left main disease in the setting of acute coronary syndrome?
My guess is practically a lot of times they get PCI, and some of these may actually go on to secondary procedures, either a second stage PCI to complete it if they're really unstable, or even bypass surgery depending upon the circumstances. I think that's a kind of a little bit of a subcategory, but at least in the XL trial didn't seem to make a difference.
Okay, there is one last question that we will take, and that's about when you talk of complete revascularization, does it imply every large and moderate epicardial artery should be bypassed or stented?
I think it's amount of functional myocardium that it subtends would be my answer. So I think sometimes PCI may actually get into trouble. Dr. Sheiban made the point about more stents. Sometimes I think we chase twigs, and that's not a good thing and may create more problems versus doing really only the important arteries. On the other hand, the surgeons, they never chase the twigs or much less, and they do the big vessels and get good results. So I think it's what I said, the amount of significant myocardium subtended by the lesion.
Well, actually, if I can do another comment, I think Syntax 2 trial demonstrate clearly that if you guide your revascularization only for ischemic lesion, you will be much close to what you can have with surgery. So right. I think, yeah, this should be kept in mind. So if you have diffuse disease, I think should be guided by functional evaluation in this patient, and to reduce number of stents you are using, just treat what is needed for patient, not for your eyes.
Right.
Right, because I think we get better outcomes with bypass. I mean, bypass surgery sort of protects the artery. It seems to be less driven by that, but we have to make sure that we avoid the stent risk.
In the complete trial as well, that there is a 2.5 millimeter size vessels are the ones that actually had to be revascularized. So I completely agree that every small twig should not be chased after. That's when we get into trouble, as it happens in everybody's lab. So I would strongly recommend not to go after any vessel that is less than 2 millimeters at all. And 2.5 and above, I think there is much higher chance of achieving complete revascularization.
Great. Thank you very much, everyone. Great discussion. Let's continue with the program. Now it's a privilege to invite Dr. Jacek Legutko, who is a professor of cardiology from Jagiellonian University in Krakow, Poland. And he has a keen interest in intravascular imaging in left main as well as non-left main stenting. He was very gracious enough to do a presentation last week as well. Today, he's going to talk about intravascular imaging in left main, Yves pro and con. So he's going to give us both sides of
it. Thank you, Raj and Goran, for inviting me to this excellent symposium. It's my privilege. And as you said, my topic for today is intravascular ultrasound and its pro and con for left main assessment and PCI. these are my disclosures. What is very important was perfectly covered by Professor Lesiak, that left main coronary artery has some anatomical features which makes angiographic assessment of left main disease often difficult and unreliable, which is important both for diagnosis and for left main PCI guidance. And at the same time, left main is the most important vessel in our coronary tree, supplying more than 70% of myocardium, and the side branch for distal left main bifurcation, usually left circumflex, supplies more than 10%, but on average is close to 30%, which is important to stress. And probably this is why most of the consensus documents published by experts about intravascular imaging, they stress that assessment of left main stenosis and left main PCI guidance are the most important indications to use intravascular imaging in everyday practice. In current European guidelines for left main assessment and stenting, there is only intravascular ultrasound mentioned, and the level of evidence is B, and the class recommendation 2A for both the use of IVUS to diagnose ambiguous left main disease and to guide PCI. Why is it so important to use intravascular imaging in all cases that you have doubts? Those are two cases which were, as you see, treated with coronary artery bypass grafting, both diagnosed by angiography with significant ostial left main stenosis, and this is the intravascular imaging which was done few months after operation because patient didn't improve after operation. And as you can see, there is almost no plaque in both cases, and this, what is visible here as a stenosis, is just the false positive stenosis by angiography. This is the distal left main 50% stenosis, and this patient was sent to our center for coronary artery bypass grafting. However, our surgeons, we had a lot of discussions for the last years, and they are very careful. And they asked us to perform additional assessment because this patient was not checked with FFR or IVUS. So I started with intravascular ultrasound, proximal reference, small plaque, big vessel, and in the distal part, eccentric plaque, but the lumen area is 7.6. For those who still have some doubts about cutoffs based on IVUS, I also performed FFR assessment in both LAD and left circumflex. The result was negative. So this is why in my everyday practice very often, and especially in those patients who are suitable for intravascular imaging, I switch FFR, but I try to confirm critical narrowing in the left main, measuring just minimum lumen cross-sectional area. When I find MLA, which is more than 6, I usually skip revascularization for left main disease if it is less than 4.5. Those patients are for sure for revascularization. If you are between 4.5 and 6, it depends on symptoms, and if you have any doubts, there is still a room to perform physiology lesion assessment. And of course, the most important feature of intravascular imaging is much more precise assessment of stent result, because with this method you can find edge dissections which are clinically significant and sometimes not visible in angiography. You can assess what is the plaque burden at stent edges, which is very important. There was a question about the should we cover in all patients ostium of the left main with the stent or not, which is sometimes tricky. So if you use intravascular imaging and you see that in the proximal part or ostium of the left main, the plaque burden is less than 50%, and there is no need to exactly cover the ostium. This is of course important to look for malappositions, and especially in left main it is important because then patient can be back in few months or years for additional catheterization and maybe stenting. And if you leave not a post stent, and if you go with your wire through stent struts, then you can be immediately in troubles. Of course, with intravascular imaging, we can look for protrusions and for thrombus. However, my task is to talk about advantages and disadvantages. This I need to stress in advance that the diagnosis of plaque characteristics and especially thrombus with intravascular ultrasound is difficult, and it is much better with OCT. And of course, the most important risk factors for stenosis and stent thrombosis, this remains still stent under expansion. And for left main, we have a little bit different approach to other bifurcation lesions, because then we have good cutoffs to assess what should have been the minimum lumen in stent area after stenting in different parts of the left main. In the body of the left main, it should be more than 8.5. In the point of confluence, bifurcation sign, more than 7.5. In ostium LAD and proxial LAD, more than 6.5. And in ostium of the third, more than 5.5, of course, if it is also stented. If you find the result, like in this very complex bifurcation, distal left main bifurcation, which I successfully treated with decay crash approach, if you find that the minimum instant RI in both segments of bifurcation lesions is above those cutoffs, then the risk of restenosis comes down to the levels which are usually seen after provisional stenting strategy. This we all know for many years. What should be the approach to treat bifurcation lesions accepting anatomy? So it means that we should size our stents according to the distal main vessel diameter, and then do the proximal optimization with the short balloon, which is sized according to the proximal main vessel diameter. And this is the patient who was perfectly treated that way. And this patient came to the cath lab with cardiogenic shock and ST elevation, acute myocardial infarction. Provisional stenting strategy was successful. Patient recovered. But few days later, the control angio was performed by the operator, because he was not really sure that kissing balloon inflations which he did for circumflex and for first diagonal were successful, and the result is optimal. And I was in the cath lab, and I asked this operator to do intravascular ultrasound, because the original procedure was guided by angio only. And this is what we have found in this intravascular imaging. Now we are with the probe in the aorta. I strongly recommend to try to do not only the pullback, but also pushback. So it means going with the probe from the aorta very slowly to the left main. And then you can of course assess immediately what you find in the left main. This stent was not exactly treated with proximal optimization technique. Balloon was too short. And you can see the malapposition, which is about 1 millimeter on both sides, which is absolutely unacceptable in a young patient. And this is another patient coming back 7 days after elective left main PCI with two-stent strategy, which was not so clear which strategy was used, but we had in the patient in the procedure description that two stents were implanted. And this patient was with troponin elevation and angiography. There was nothing very typical, so there was no signs of thrombus. There was also only this residual stenosis in the proximal ostial part of the left main, which was about 20–30%. Not very clear why this patient experienced acute MI and troponin release. But if you perform intravascular ultrasound, everything becomes clear. This is the intravascular probe, which is going to the stent. This stent crushing partially another stent, which was implanted probably as the first one in the left main. So you can see the stent under expansion in the mid part of the left main. Even without measuring, if you compare to the distal reference, it's absolutely under expanded. There is some additional metal within the stent, and of course in the distal left main there is also a stent malapposition. So what this is for me not very rare situation when you use angio guidance that you leave such unacceptable result. In this patient I did only one balloon inflation with appropriately sized balloon. I again inflated and crushed this another stent, and as you can see there is now much better stent expansion, and this is for me the best comparison of IVUS guided to angio guided strategy for left main. Of course, it's good not only to do the final IVUS assessment of the result, but to start the procedure with IVUS interrogation, to do the measurements in the proximal reference, in the distal reference, in both left main LAD and also both left main and circumflex, which means that I usually in majority of cases perform two pre-interventional pullbacks, and I repeat this after the procedure. If it is provisional stenting, I only check the main vessel. If it is two-stent strategy, I check both. Of course, if you have doubts about clinical significance of the lesion, you measure minimum lumen cross-sectional area. You can also check for the plaque burden and lumen area in the ostium of the circ, because this can be the factor which influence your strategy and changing from provisional to two-stent strategy. If you use automated pullback for mechanical probe, you can also measure the length. And very important for left main, as I mentioned, to check what is the plaque burden in the ostium and proximal part. If it is more than 40%, I usually cover the ostium with the stent. If not, I do not cover, which makes the procedure much more easy. And of course, with intravascular imaging, you can much better check for calcifications, and you can use appropriate lesion preparation method, balloons, lithotripsy, or in most severe cases, rotablation. And this is the case example, and the patient you asked about the use of left main stenting in acute coronary syndrome. This is actually very young gentleman, 33-year-old, during cardiopulmonary resuscitation, and with diagnosed STEMI of anterior wall, and this is angiography. What you can clearly see, there is a haziness in the distal left main and ostium of the LAD. So patient received typical treatment, and the operator started just with aspiration, which significantly improved the situation. He aspirated some part of thrombus, and the hemodynamics improved. Patient recovered, and this is intravascular ultrasound. 34 years old gentleman. This is not spontaneous dissection. This is small eccentric plaque, but probably this plaque ruptured and caused this event. However, plaque characteristics, as I said, are difficult. Here for me is a thrombus. However, if we use for this particular indication OCT, it would be much better. This patient was treated with stenting, 4.0 diameter drug-eluting stent. This was post-dilated with non-compliant 5.0 balloon in proximal optimization technique. And this is the result. What we usually check after the procedure, we are very interested about the distal edge of the stent, not to overlook the dissection. As I said, the plaque burden at the edge should be no more than 50%, less is better. So the distal part is perfectly covered, and the stent is well opened. We can see just at the side of bifurcation some small thrombus protrusions, and then we are going more proximally, and here this 5.0 balloon was probably not enough, and just in the ostium you can see also some stent malapposition in this 34 years old gentleman. So what we did, we used another 5.5 balloon, and this is the final result, and you will never see the difference between the previous angiography and the current angiography, because some features, some characteristics are only visible on intravascular imaging, and this is the final stent opening in the ostium and the perfect result of the procedure. And this is the situation which will be more and more often in the cath lab. So patient coming back for additional procedure after left main PCI. Radial approach and multiple tries to engage the guiding to the ostium of the left main, which was not possible. So operator changed the strategy, used femoral approach, and this is the IVUS after wiring of the LAD. The stent well opened, very well covering the ostium, however protruding to the aorta. As you can see, this is the protrusion of few millimeters, and this is why it was not possible to engage the ostium with the guiding. And actually this catheter, this IVUS catheter, is going through the stent struts. If you go There, with the balloon, you inflate the balloon in LAD, and during your removal of the balloon, it's possible to also withdraw the stent from the left main. So I accompanied my friend who did this procedure, and we spent a lot of time, and with the body wire, this wire I used as a body wire, and I tried many times to advance another wire with IVUS control, and finally I was successful. This is another pullback, and you can clearly see the wire, the additional wire within the stent. And now we see, and it is easy to check, that your wire, the probe is on the wire which is exactly going through the ostium of the stent. However, what is also clear for you, that these multiple manipulations caused stent distortion in the aorta. It's not a problem if you diagnose this, because then you just need to inflate your balloon, and this is the final result and beautiful opening of the stent with additional balloon inflation. So this is corrected. The problem is that we will see more and more such cases coming back to the cath lab. And of course, longitudinal stent distortion is a problem. This was mentioned by Professor Lesiak. This can happen during balloon pullback or during gel wire pullback, and this influence patient outcome, which was beautifully demonstrated by Marciej. And this is the graph, which is my everyday practice, to be honest. This was published by Professor Park a few years ago, and this is the scheme how to deal with left main PCI. You should start with pre-interventional IVUS assessment, which is important to check for clinical significance of the lesion, and then to decide on the strategy, provisional or two-stent strategy, and also to check the result of the procedure. Because if you do this, if you guide your procedures with intravascular ultrasound, then you can achieve better long-term survival. And I exactly know that this meta-analysis is based on the registries which were published, and there is no unrandomized trials. But I will, because the advantage is lower mortality, I would still treat these results as very clinically important. And if someone is not convinced, he should immediately go for randomized trial. And this is also important. We were talking about Excel and Nobel. Please keep in mind that 77% of patients in Excel and 74% of patients with Nobel, the PCI was performed with IVUS guidance. So if this is our roadmap, that in some patients we can get a good outcome and we are competitive to surgeons, we should use exactly the same strategy. So it means intravascular imaging guidance for the procedure. This is of course true that for low volume operator, the advantage of using IVUS is maybe more. However, in this analysis, it was also a clear trend toward better survival in patients treated by more experienced operators. To summarize, these are the clear advantages of intravascular imaging, IVUS, intravascular ultrasound, extensive clinical experience. Pre-intervention imaging is possible in almost all the patients. And of course, you can measure not only the lumen dimensions, but also the media-to-media dimensions in those patients with atherosclerotic plaques. And of course, the IVUS predictors of restenosis and stent thrombosis are well defined. At the same time, there are no disadvantages which are typical for OCT, so we don't need to administer contrast, which is very important, especially in patients who are hemodynamically compromised. And I believe that this is also important to stress that, particularly for left main, this is very important that with intravascular ultrasound, you can exactly assess the ostium and the proximal part of the left main, and you can also very well assess the big left mains, those with 5 or 6 millimeters in diameter, which can be difficult with OCT. Of course, the completeness of left main evaluation, distal left main bifurcation, is better with OCT, and this is why we discussed this with Patrick Sirois 3 years ago at the EBC meeting, that probably there is the new device, dual mode IVUS OCT catheter, and if we think about possible clinical indication to use this catheter, probably the left main PCI optimization can be one of these of these indications. My take-home message is that, you know, when Jean asked me this question, when do you use IVUS for left main PCI, I will always answer before and after stenting. So there is still some disagreement between us that IVUS should be mandatory for all left main PCI cases. However, we agree on this, which is not yet in guidelines, but in my opinion should be with class 1 indication, and of course as a expert agreement that for the beginners, in case of two-stent strategy and in case of any suspected state failure, IVUS guided stent optimization should be the standard of care for unprotected left main PCI. Having said that, I thank you very much for your attention, and I'm open for questions.
Thank you very much, Jacek. We'll take a couple of questions. We have quite a few questions from the audience already. One question is about, in case the demonstrated discordance between IVUS and FFR for the left main means MLA of less than 4.5 and FFR of more than 0.80, which value should be adopted in the current era? And this will be open for all the panel.
The patient that I presented was exactly concordant because MLA was 6.7, so or even 7.6, so it was more than 6, and so there was both IVUS and FFR. They said this is not a clinically significant lesion which should be treated. When I am in the gray zone and have some doubts, then I do FFR, and this is for me the final decision-making parameter. This is my approach.
We'll take one more question. Does IVUS cutoff value of MLA of 4.5 millimeter apply to all races? And given it was calculated from the Asian trials and registries with a known a bit lower BMI, should this issue be balanced?
You know, in our consensus document, which was published by Gary Means as a leader and European Bifurcation Club, they stated that just clear 6 cutoff value for European and for Caucasian population should be adopted as a one cutoff value. This 4.5 is for Caucasian, and this results, the correlations came from Asia. However, you know, because there is still a lot of discussions on that, this is why in expert consensus there is a decision to use the less than 4.5 as a for sure ischemic lesion, more than 6 for conservative treatment, and if you are in between, you can think about additional assessment if you have doubts.
Great talk, great discussion. I think there are several other questions. I encourage the panel members to look in the Q&A box and try to answer some of them. But in the interest of time, we'll continue with the program. It's now a privilege to invite Dr. Yutaka Hikichi, who has taken a very special accommodation from Japan. It's late in Japan right now. But he's a professor of cardiology at the Saga University School of Medicine. He's a frequent contributor and scientific advisory board member of C3 meeting. And he will now discuss intravascular imaging in left main, OCT, pro and con.
Oh, can you see my presentation? No, not yet.
I see you right now. If you could share your screen, I'll be able to see your presentation.
Okay, can you see? Not yet?
No. Not yet.
Not yet. Oh, okay. Sorry.
You have a green button and you have to share the screen.
Like
yes.
At the bottom of the, if you hover over your picture,
at
the bottom of the screen, there is a share screen button.
Are you okay? No, I'm sorry. So I can understand about the system of the.
At the bottom of your screen.
Yes, bottom screen. Yes. I share.
The green share screen.
Yes.
Button. Click, and then you will see your screen.
Yes. and I click the PowerPoint.
No, you
But
should click the share screen first.
Share screen, share screen, share screen.
It's in the bottom.
Look, the green button.
You put
At
your
the bottom.
cursor over your picture, and at the bottom of your screen,
Yes.
it will come up, share screen, and you click on that.
Sometimes if you don't see it, you might have to log out of Zoom and come back into Zoom. Sometimes that is a glitch that happens.
He is co-host, so I am certain it's there.
Yeah,
Yeah.
it should be.
Yeah, yes. Oh, I push the not yet?
Not yet.
Yeah.
Do you push on share screen?
Yes, yes. I push the yes. I push again.
Yeah.
No, not yet. Yes or not? Not yet. Hello?
No, not yet. Not yet.
Not yet. Yeah, sorry, I cannot connect into this the upload my data.
Dr. Hikichi, can you select your PowerPoint screen and then
PowerPoint.
hit?
Yes, I think so. I hope so. However, the desktop is not the PowerPoint. I cannot choose the PowerPoint.
I'm going to take a
after you
picture
press
of
share
my screen, and I'm going to send it to you, Dr. Hikichi, so you can see what I'm talking about.
Okay, okay.
So while I do this troubleshooting with Dr. Hikichi, perhaps
Yes.
We will do one more talk and then we'll come back to you.
Okay, thank you.
And I know that Dr. Gabor Toth has been very kind to be available, even though he's on call today. And he's been waiting to do his lecture. Dr. Toth will speak on stent selection in left main, understanding the stent geometry. Gabor, are you ready?
Yes, thank you very much. Do you see my slides?
Yes, we see.
Great. Thank you.
Excellent.
Excellent. So good morning, everyone, and thanks a lot for inviting me and involving me in this program. I'd like to discuss with you some aspects of the stent selection, how the stent design has an impact on, let's say, the success or failure of left main stenting. When we talk about left main PCI, of course, it's a challenge for the interventionist and the patient, but it's also a technical challenge for our stent devices. And I try to categorize these challenges as follows. There is what I call a proximal main branch challenge, a left main ostium challenge, the jailed bench challenge, and the guiding catheter challenge. So let's talk about this one by one, and let's start with what I call the proximal main branch challenge. We all know from Finney's law what is the diameter relation between proximal main branch, distal main branch, and side branch. And of course, it explains very well that there is a certain diameter mismatch between distal main branch and proximal main branch, in this case, the left main. But from this formula, we can also understand that the bigger the side branch, the bigger this distal to proximal main branch mismatch. So in case of left main, where the side branch is almost always a large vessel, there is a huge mismatch between the distal main branch and the left main itself, whichever branch we select distally as distal main branch. So this diameter mismatch it's even more important for left main than probably for any other bifurcation. Of course, as you have heard, that we can correct it with the proper pot, proximal optimization, which has a critical importance, but it is also a critical importance that from this device point of view, we can perform it properly. You have already seen during the previous talks this famous table from Nicolas Foin's group. What is important here is the different stand designs and stand platforms. And we have to also admit it's a nice and extensive table from this work, but it doesn't cover the whole stand portfolio what we might have in the lab. We know it for these few stand devices, but maybe we don't know it for the other ones, where the different designs of stands changes from small designs to large designs. And why is it important? It's important because these are the expansion capacities. You have also seen this before, and you see that for a 3 millimeter stand, for most platforms, the expansion capacity is not more than 4 point few, and 4.1, 4.2, it's quite often below the true dimension of the left main. And why is it important? It's very important because before you implant your stand, your first stand coming from the left main going to whichever distal branch, you have to understand whether this stand will be able to cope with the dimension of the left main. And you see here, when you switch to the larger platform, the maximum expansion capacity becomes markedly larger, but even then you are not beyond 6.0 millimeter. So I would say that especially when you perform imaging at the beginning to understand the dimensions, you should consider as a potential technical limitation of a left main PCI is the dimensions. Can you reach proper apposition with this device in the left main, yes or no? For instance, the stand with 5.3 millimeter maximum expansion capacity, well, we have to admit it's often below the true dimension of the left main. So with such a device, it can be tricky to reach a proper PCI result. And for instance, I just added here, with this expansion capacities of a 3.0 stand, the side branch according to Fine law should not be above 3 millimeter, because otherwise these dimensions are not fitting. So this should be kept in mind before we select which vessel we take first and which device we take from the shelf. So checking for feasibility of your device for that given left main is crucial. The second, what I call the left main ostium challenge, is the following. It's against the same story what I said before, the distal main branch, proximal main branch mismatch, which can be corrected by massive proximal optimization. But we have to again look at our device, what we selected, our stand, what we selected. There are different platforms, different designs, different connectors, because what happens during massive proximal optimization or overexpansion, we straighten the crowns, what you see here in black, so it will be straightened. Actually, what remains from the length of the stand, what gives the length of the stand is nothing else but the connectors. So if you have a stand with short connectors, then there is a massive foreshortening of your stand, while with another one, with longer connectors, the foreshortening is much lower. Why is it that important? It's important because you see here, okay, I just selected a couple of stands, short connectors, long connectors, very short connectors, almost no connectors, long connectors. So there are different devices. You should check what you have on the shelf, how it's designed. And why is it important? Because as you said, covering the ostium, yes or no, which projection, how precisely to position your stand. You put your stand, you nail it to the ostium, you do the pot as explained, it's very important, very good. But then if you have a stand with massive foreshortening by this post dilation, then after pot, you will miss the ostium. You dilate it, but you don't have any stand there anymore. So this should be again somehow considered by selecting the stand. And of course, this foreshortening which can reach a couple of millimeters. It depends on how much overdilation you need to perform and how long was the left main. So let's say if you have a 15 millimeter left main where you overdilate the 3.5 stand till 6.0, you can easily lose 3-4 millimeters from the ostium. So even though you are nailed very, very accurately to the ostium, your stand, after post dilation, it's not covered anymore. So the next one is what I call side branch challenge. So jailed branch challenge. We have to check whether we can reach proper opening towards the jailed side branch. And I have to admit, I did not find very accurate data neither in the literature nor from the industry. This is what I get for one stent, but such accurate explanation of the maximum opening capacity of a side cell, I did not find it for the devices what we have. But what we want to avoid for any patient is this image when you reach the side branch, want to open the side branch, and your balloon cannot open because the cell of the stent doesn't allow to go bigger. It's limited. And how does it come from? Well, you will see that whether we can open how big are the cells. There are major differences between different stent designs. And there are some stent designs where for instance, like the Promus, but even at their integrity, where the proximal cells are smaller than the more distal cells. So you also consider through a more proximal cell, you cannot reach as big diameter towards the side branch while rewired and you want to perform KISS as through a more distal cell. This is not proximal or distal cell covering the side branch, but in general within the stent design. So this should be also considered, and I'm also interested, maybe at the end the colleagues can comment on this. I don't have this exact parameter for different stents, but what I did, I simply tried with the stents what we have on the shelf just to understand what opening I can reach. I would suggest you also to have a look maybe in bench for the devices what you have on the shelf to understand which might be considered for a large side branch and which should be avoided. But in general, where does this side branch opening come from? Well, from the description of your device, you can understand the more crowns you have within one ring and the less connectors you have, the larger a cell can go. So if you see here, for instance, if you have 6 crowns with 3 connectors, then the cell size will be most probably much smaller than for a device with 10 crowns and 2.5 connectors. But this is what you can consider as let's say a surrogate parameter to understand what is the cell opening of maximum cell opening capacity of the device that you have. And finally, it was also discussed during one of the previous talks, is what I called guiding catheter challenge. Well, when we select our guiding catheter, of course, if it's a gentle one, then it's less supportive. If it's a more supportive, then it's more aggressive. And we have to consider this while dealing with our left main. Why? Because our stent is just placed to the tip of the guiding catheter. And what can happen, especially when you still have a jailed wire, it can simply by the moving of the guiding catheter, if you are not careful enough, it can easily longitudinally damage your just implanted stent. And of course, it needs, we can say, it needs a careful interventionist, but it also needs a certain longitudinal strength of the device that you are dealing with in order to avoid this. And there is, again, important differences between the different devices. And as compared to the cell opening here, it's true that the more connectors you have, the higher the longitudinal strength. And this was the story a couple of years ago with the first Promus devices, which were quite weak longitudinally. Then it was improved by adding additional connectors between the first 3 or 4 rings. But what does it mean? It means that for the first 3 millimeter, the device is stronger, but below it's again weaker again. So if you deal with the longer left main, then when you implant your stent first, it will have a long malapose, let's say a floating stent in a long left main. The longer the segment, the weaker the stent. So you have to be more careful with your guiding to avoid longitudinal compression and kind of messing up your procedure before it really started. And you see here in this study from Ormiston's group showed that actually that time the Promus element one stent was the weakest one, while the Biomatrix was the strongest one. The other stents were somewhere in the middle. But in general, what is true, the longer the segment where you have still the malapposition, let's say, for instance, before performing the pot, the higher the risk that you cause longitudinal compression and distortion of the stent. So finally, how it has an impact on different procedures, or how we can consider this for these different procedures. When we talk about provisional on T and protrusion technique, then with what I called proximal main branch challenge, there is only one stent which has to cope with it. This is what is coming to the left main. With the ostium, it's also only the main branch stent. The jailed branch, so the cell opening, it's only for one stent, released to one stent. Why with guiding catheter, probably we can damage both stents, so it should be considered. For culotte technique, actually, it's even more tricky because both stents has to have the capacity to reach the diameter of the left main, so it should be considered while selecting the stent for the side branch and main branch. While it's also very important that both stents, so you have to select the stent where the cell can open to the diameter of both branches. Why? Because the stent what you put in the side branch, its side cell has to open up to the diameter of the main branch, while the stent in the main branch has to open up with the cell to the size of the side branch. While if any of these stents are, if the stent has a cell which is smaller than any of the branches, actually it's a kind of dangerous situation, because then you cannot reach proper opening with the crossing stent, resulting potentially in massive malapposition. And finally, with DK crush, it's a similar story where the cell opening has an importance, because the main branch stent has to have a cell opening capacity for the side branch diameter, while the side branch stent has to have also a cell opening capacity to the side branch diameter. These are the aspects that I would consider especial for technical challenges for our left main stent. And what is important that actually not all stents are the same for left main PCI. Therefore, it's very important to understand our devices prior taking them from the shelf. Detailed technical data and analysis is not available for all the devices what we might have. So therefore, either further research is needed. Otherwise, I would even say that it would be fair from industry partners to provide us with this data before we start use them. And finally, careful technical considerations and understanding of these aspects is really necessary for all of us, for all the users. And of course, clinical relevance of these aspects still has to be proven. Thank you very much.
Thank you very much, Dr. Toth. It was a fabulous lecture. There are several questions from the attendees. We'll take a couple. Does open cell and closed cell stent make a difference in the bifurcation?
Well, to be honest, real closed cell design doesn't exist anymore, so far I know. So this very old closed cell designs with 5 or even more connectors all over, it doesn't exist there. In these terms, the worst design has 3 connectors at the moment, so far I know, or at least from most of the stents. But of course, it's true, if the more connectors you have, the smaller a side cell can grow, so it can markedly limit the procedures what you want to perform.
Which stent has the longest connector?
It's a very good question. I don't know which has a longer connector from these stents. What I demonstrated here, actually the science stent has a special relative long connector there. The connector is exactly as long, plus one little U form in it, as the distance between 2 rings. So it means that when you open up the stent to a theoretical maximum, well, all the rings are completely circular, it practically still maintains the complete length. The only what you lose is in total the length of one crown. This is the from design, I would say this is where you should expect the least shortening.
Well, actually it depends on connection. Where is connection meeting? That means peak to peak or valley to peak. So this will make longer or shorter the connection between one strut or other. So it depends on the design of connectors, whether it's peak to peak, valley to peak, or which make difference in length.
Yeah, if I may show here, I don't know whether I can still show. So this is just
exactly.
So you see here in this image, you have the connector actually
valley to peak,
valley to valley, and it's even longer than the distance due to this little U.
Yes.
It means that here the shortening of the stent will be minimal. While when you look here to this other design, this might straighten a bit, but when it's a peak to valley, when you open
it is peak to peak.
Well, peak to valley.
No, this is the connection between this peak and the second peak.
Going opposite direction.
Yeah, but when you can imagine once it's straightened and this one straightened as well, then the only distance between the two rings will be this length of the connector, so it will become minimal.
Mm-hmm.
Yeah, okay. It is also worth to mention that when you stretch expand the stent, you are not losing the radial strength, because people think that if you overstretch the stent, you may lose the radial strength, which is the opposite, because the connectors become more perpendicular and actually they increase the support. Yeah? So you're not losing radial strength of the stent.
Yeah, it's a very good point. So overexpansion actually increases the radial strength. It's like in architecture. So when you make a whole circle at the end, a metallic circle, it's the strongest thing.
Yeah.
So I think one of the points from your talk is that, well, in the Q-LOT technique, you need to implant a stent from the circ to the left main that can actually accommodate the size of the left main. And we just saw in the previous talk that, well, the left main is almost always 4.5 or above. So should we always implant a 3.5 platform or larger from the circ? Do we have any 3.0 platforms or smaller that we can actually use in the left main setting, extending from the circ to the left main?
I don't believe so. I agree with you that even the cost of overdilation of the LAD, I would rather go for a 3.5 platform, because I see more risk in a suboptimal result in the left main than in a potential oversizing and bit of dissection in the LAD, which you can correct. Otherwise, you put a too small stent in and you will never reach good apposition in the left main. You even compromise your circumflex results if you go for a culotte technique. Having in the ostium the ring plus the other stent undersized cannot be opened up properly, and I see a bigger risk for the patient.
Okay, so thank you very much, Dr. Toth. Fantastic, a lot of interest in this particular topic. There's still more questions in the Q&A box from attendees. You can take a look at them if you have a few minutes. But in the interest of time, I'd like to continue the program. It's now my pleasure to invite Dr. Ramesh Daggubati, who is the Associate Director of West Virginia University Medical Center, Cardiology Department, who is now going to discuss left main 001 lesion treatment. Ramesh, it's on to you now.
Thank you. Sorry. Thank you very much, Dr. Raj Dave and Goran Stankovic and all our colleagues. It's a really great pleasure to see all of you here. Can you see my slides now?
Yes, we can. Looks great.
Okay. Good.
Oh, yeah.
Yeah.
Looks good. Yeah, looks good. Yeah.
So how do I approach left main bifurcation 001 lesions? And I have no disclosures. So bifurcation, as we said, accounts for about 15 to 20% of our PCIs, and there's has to be an individualized approach based on the anatomy and dynamic changes and the angles, as we have already heard about, and the stent choice, the geometry is very important as well. So when it comes to, in memoriam of Dr. Medina, who passed away in 2017, this is more of a research tool. I think you look at classification of bifurcations to mainly simplify as giving a score of 0 or 1 if it is no disease versus there is disease, to the main branch, proximal, the main branch distal, and the side branch. So if you see in the bottom right, I said 0, 0, 1, that is actually only just the involvement of ostial side branch. There is about 5% of all the bifurcations. So if you think about it in your real practice, if there is only 100 patients, you take in a year that you do interventions, and 15 of them have bifurcations, and 5% of them will have 0, 0, 1, which is really a low significance patients. What are the options? So strongly consider medical therapy, balloon-only strategy, cutting drug or cutting balloon with or without drug-eluting balloons, and precise stent placement. I used to call it a stopper technique or a stent drawback, and the tap and Zabo techniques are the ones that are used. So I think more than Medina, look at the length of the lesion in the side branch. If there is more than 10 millimeters disease, go after the side branch. If it is just ostial lesion, short segment, less than 10 millimeters, it is probably not worth doing a therapy with stents for that lesion. Angle between the main vessel and side branch. And are you prepared to stent the side branch? And are you also prepared to switch to a 2-stent strategy? These are all the things that we have to think about. Even if you do PTCA alone, wire both vessels, protect the main branch always, and cutting balloon can be done. It can have a control or a limited dissection, and then actually treat the segment if you have the choice of getting a drug-eluting balloon in your cath labs. And the shorter DAPT is an advantage in this group. So this is the data for drug-eluting balloon, 49 patients with the 001 treated with drug-eluting balloons. 50% of them had cutting balloons pre-dilation, and the stent implantation was needed in 14%. And at 1 year, the TLR was 14% as well. So this is a stent drawback technique, and which actually is really important to know how to do it as well. And because I have actually messed it up a couple of times, and so the main vessel balloon is inflated to 8 atmospheres. I used to choose a compliant balloon, but now I would actually recommend a non-compliant balloon. And the stent from the circumflex is pulled back against the inflated balloon until a dent is seen. So this is very important, because if you are not careful, the balloon can come out during a respiration or such into the main vessel, and then you now resorted into a 2-stent technique. The stent is deployed, and both balloons are deflated, but the TLR, this is shown by Annapurna Kinney from Mount Sinai, is very high, so still 20% TLR, okay? So this is a patient of mine where I thought, okay, we can easily do a precise stent technique. Of course, it's not in the ostial circumflex. I just wanted to show you, even with all the experience we get in the last week, and I was trying to teach our fellows, the FFR of the that OM2 was IFR was 0.83, which is significant. And so we thought we'll precise stent placement. And unfortunately, the stent came back as he took a deep breath. But angiographically, it looked good. And we said, okay, that's probably okay. Just leave it alone. And then, as you can see, he developed ST elevations immediately while on the table. Within few minutes, we went from the femoral route. And you can see that there is a dissection in the main vessel. Just imagine having that in the left main, and you'll be struggling a lot. So this has been obviously converted to a DK cross technique, and then we were able to reduce the amount of dissection that was in the main vessel. Zabo technique is, I think, is a cool technique. If you can get to do it, it is easy to. So you have to inflate the stent while it is on the balloon, on the bench, on the outside the body. Flare it up a little bit, make sure you can get another guide wire through the proximal part of the stent, and then recrimp, and then that branch, that stent is advanced into the LAD with the other wire going into the circumflex, so that exactly you can anchor it, or vice versa if you're treating the ostial circumflex lesions, as my talk is about. So here are the steps. Inflate the stent to low pressure, less than 4 atmospheres, to allow passage of the second guide wire. Manually lift the distal strut, and then the stent is then manually recrimped onto the balloon and delivered over both the guide wires, and the stent is deployed at 8 atmospheres. Then you remove the anchor wire, and then you can go to high pressures on the stent. So this was described by Szabo in 2005, and I think there has been some success in this. Actually, he reports a TLR of actually around 2% with this technique. If the bifurcation angle is narrow, all the above said techniques are good. If there's a wider bifurcation angle, including tap stent technique, especially in patients who had a prior stent from left main to LAD. But if the bifurcation angle is narrow, this is probably just go ahead and do a sort of a culotte or provisional stent strategy, stenting from the left main into the circumflex and doing a proximal optimization in the left main. So this has been a study registry of 40 patients that showed a very low TLR as well at a 2.5%. And this has been published in Neurointervention. So the reason I mentioned about the length of the lesion is very important is actually from this quoting Stankovic and Zimarino's paper from a presentation from Euro PCR 2019. They actually looked at side branch lesion length in 2 tertiles, 3 tertiles. They have differentiated those patients who have disease whose length is longer than 10 millimeters and or not. So in that, actually, you can see that if you compare the 690 pairwise matched patients and controls with no side branch lesions, in the red is people who had lesion length more than 10 millimeters, and there is a much more higher probability, survival higher probability with and the red is no disease, I'm sorry, and in people who have higher disease in 10 millimeters, they had higher event rates, so you can see that there is higher event rates in people as cardiac death is about 12%, MACE is 12%, and cardiac death is 4% in third tertile patients of 254 in whom the lesion length is more than 10 millimeters. So those are the people, if they're not treated, they'll actually have a higher event rate. So we should do that. So quickly in the next few minutes, I'll present this patient, a 40-year-old non-smoker, had multiple visits. So I'll quickly go over. The index procedure was actually a cipher to LAD in 2006. As you can see, it was thought of to be precisely placed up to the proximal LAD, osteal LAD. In 2010, he comes back with the osteal circumflex lesion, and this is 001, and we tried to do it actually with a balloon, and that caused a dissection. Then we had to resort to actually a stent from left main to LAD, and the side branch of, and then osteal LAD was pinched. Then we had to extend another stent from left main into LAD as well. So post-dilatation, simultaneous kissing balloon inflations were done, satisfactory result. But 4 months later, he comes back again, young guy. So the question was, with this type of restenosis, again, mainly at the osteal circumflex, which is much more than osteal LAD, should we do the same DES, different DES, DEB, or surgery? So we thought, okay, let's do DEB. This time he was in India. We did DEB and LAD and circumflex. So this was a good result. And then 6 months later, check angiogram. Now he has actually diseased both, unfortunately, osteal circumflex as well as osteal LAD. So EF is 60%, and maybe we should have just definitely deferred him for bypass surgery at that time, but he was not willing. So we went again with the DK crush technique, using different promo stents at this time, and got an excellent result at the end angiographically. So whenever there is instant restenosis, look at all the things: drug resistance, hypersensitivity, stent deformation. And I think using IVUS or OCT is very important in these people to avoid stent deformations and fractures and malopposition as well. So again, repeated, there is restenosis again. And Yves, as we said, it's very important. DK Crush 8 will be addressing that use of Yves in left main bifurcations, and we have to wait for that. The role of brachytherapy is also there in people who have recurrent instant restenosis. And in these patients who had up to 3 years, the TLR is still high, unfortunately, but sometimes we are left with no option other than brachytherapy to avoid multiple layers. So this patient had a brachytherapy, but it comes back with the stent thrombosis, and that was treated with the balloon alone. And then till 2015, 3 years later, thank God he did not come back, and unfortunately I lost touch with that patient. So the role of imaging is very important in 001 lesions, OCT or Yves to know stent malposition under expansion, and a technical inadequacy will increase the risk of stent thrombosis and restenosis. FFR is definitely complementary to all imaging. I do not say that you should not use FFR. You should use FFR to gauge whether you want to intervene or not. So the proposed algorithm is for a restenosis of 001 would be if it was a bare metal stent, or use a DES or a drug-coated balloon. And if it is a drug-eluting stent restenosis, use a brachytherapy, or again another DES or DCB. But in recurrent drug-eluting stent, I think brachytherapy or bypass surgery is probably the better. So how do I deal with the 001? Stress test or FFR to see if this lesion is significant. Medical therapy if FFR is more than or equal to 0.75. And even if there is then significant FFR, PTCA alone, and the drug-eluting balloon if you can get your hands on it. And so I was first understand the etiology, and either cutting balloon or sometimes even atherectomy has been done in people with calcified lesions, and a DEB or just a POBA, but obviously DEB is better. Avoid multiple layers of DES in this area, and brachytherapy is an option as well, and CABG or medical therapy is still a great option. Thank you for your attention, and I appreciate again for all the panelists and for the attendees. Thank you.
Thank you very much, Dr. Daggubati. We'll open up discussion from the panel. Any comments from panel members about treatment of lesion 001 in left main bifurcation?
So for me, in majority of cases, I just use this inverted provisional strategy. So I stand just from the left main towards the circumflex artery, with opening cell towards the LAD and kissing balloon inflation. And if everything is okay with LAD, I'm really, I leave it like that, so I do not try not to stent the LAD lesion. So I think that's the best technique we can use.
Yeah, that is the best, and that's also the safest, actually.
Yeah.
Right, I think I completely agree. The inverse provisional stent strategy is the best one.
And the same applies for any other bifurcation. LAD diagonal is the same.
Yeah, reverse provisional is a good strategy. I think in many cases, if you look with Yves, you still having a room to limit your stenting only to CERT in many cases. So if you can do it, I think this is another option that you should take in consideration. But again, you should check before with Yves whether you have still having a room to position the stent within circumflex without protruding a left main.
So in reality, that is extremely difficult.
Yes.
So it is really so difficult if you have true osteal circ lesions to leave. Sometimes you're lucky, but in most of the cases, you either have protrusion into the left main bifurcation, or you simply do not cover the ostium. It's really tricky to hit that sweet spot. And
actually, I totally agree with you. If it is really osteal lesion, then you cannot just place the stent within circumflex. You should protrude, then go with reverse provisional. That's a good option. I'm speaking about many cases having very proximal lesions. On angiography can seem that it is osteal, but if you check with Yves, ostium is free. Then you can you can just select your stenting for in circumflex and without protruding.
I'm really doubtful about that without having the data, because you will have an edge. You will have an edge where you will have some level of reaction just in the circ ostium. If you place a stent that ends 2-3 millimeters from the ostium, you will have the edge reaction, which you will see in most cases. And in that circ ostium, that is really susceptible to then having a restenosis then.
I agree, and I think what you mentioned, that it's not clear on the angiogram whether there is space in the ostium or not, but then you will see exactly during the positioning of the stent, it will be the same, that you don't know where exactly the ostium is to position it. So what you don't see on the angiogram at the beginning, you will not see during position of the stent either, and then you are just protrude too much or too distal, and they are not predictable anymore what to do.
One question from Dr. Murasato in Japan. How about performing a atherectomy for a side branch plaque in 001 lesion, either DCA or rotational atherectomy followed by DEB?
Dr. Samin Sharma had a great experience in even including actually diagonal ostial rotational atherectomy with good results. But if you really have to use the rotational atherectomy, I think, calcium will never be just at the ostium. It does extend into the main vessel. I would say document that with an Yves or with OCT. Make sure that the lesion is just at the ostial. And if it is truly at the ostial, I would actually be wary of just doing rotational atherectomy. It can be done. It has been done as well. But I think, be prepared again to go for a 2-stent technique in that patient, because you might end up with the dissection. And the same thing holds important even for a drug-eluting balloon following a cutting balloon as well. So as long as you know the limited dissection, keep the patient on the table, wait for some time to make sure there is no acute vessel closure. I think that will be okay. Maybe treating even with 2B3A is important in such patients.
Great. Thank you very much, Ramesh. Thank you very much, all the panel members. We'll now continue with the program. There are several other questions from the audience. This is the presentations are so great and the interest is so tremendous. I'll try to answer some of the questions online, but we'll now move on to the next lecture. It's a privilege to now have Dr. Vladimir Dzavik from University of Toronto in Toronto, Canada. Also part of the C3 Scientific Advisory Board and a very well-known physicians in expertise in coronary bifurcation. So Dr. Dzavik's today's talk is going to be about upfront 2-strand strategy. In other words, DK crush is my new standard.
Unmute.
I just did, thank you.
Yeah.
Thank you very much, Raj and Goran and everyone. It's a pleasure to be here, and what a great discussion, great talks thus far. Can you see my presentation?
Yes, we see it.
Yes.
Okay, so you see my slides, but now hopefully you will see my presentation. Excellent. So DK crush is my new standard for the 2-stent strategy. I would think that would be correct for me in most instances. Why is that? So I misspelled our good friend Tanvir Rab's last name here, but this is from his and Xiaoling Chen's publication from a couple of years ago on a algorithm, if you wish. So yes, 2-stent strategy is not essential for all bifurcation, but really for true bifurcations with significant disease. So whenever you have either at least a 70% side branch lesion, or the length is greater than 10 millimeters, which would be considered a complex lesion, the ABC, the Asian Bifurcation Club consensus is to go for 2 stents, and with that, meaning the side branch stent first, especially in situations where you consider it that you might have difficulty recrossing into that side branch if you stent the main vessel first, which is not that uncommon, and that the DK crush is really the best, technically the best option. And I certainly agree with that.
I am not seeing the slideshow now.
Oh boy. So I wonder if we, okay, I'll stop share.
Yeah.
I will share again. Can you see it now?
Yep, now we see. Yeah.
Okay.
Perfect. Yeah.
Was it just this slide that it stopped?
Yeah, yeah.
Okay. So again, imaging is strongly recommended. That's already been discussed elegantly previously. So why the DK crush? Well, this is a fly-through OCT that we did with a reconstruction that was done by Hiram Becerra in this publication, showing really excellent coverage of the ostium of the side branch. In this case, this was not a left main bifurcation, but I think the principles are the same. Very little, if any, protrusion, malapposition, maybe very slight right here, very slight, but really an excellent result that you can achieve with the DK crush. And yes, it is technically perhaps a little bit more of a demanding procedure, but not too demanding, I think, for most people, probably not more demanding than some of the other techniques such as culotte that are done. And I think more readily amenable to an optimal result. So this is actually not entirely about left mains, but it's a new publication, relatively new publication. It's the Nordic Baltic 4 study, which was done December 2008 to December 2012 and published just this year. So our colleagues obviously had some challenges in the publication process, but I find this to be a very good study where a total of 450 patients were, I believe, close to 450 patients were in fact enrolled in a simple versus complex group. Now, only a minority of the patients of the subject in this study actually had left main bifurcations, but some did. And this was actually the result. Now, the conclusion of the study was that it was a negative trial by virtue of the fact that these differences actually were not statistically significant, but trended. But indeed, the conclusion was that there was no benefit of two-stent technique versus the one-stent provisional technique in these patients. There was pretty tight adherence to the one-stent technique. I believe only about under 4% of patients in the provisional technique actually underwent deployment of a second stent in the side branch. So it was really a well done technically trial. Let's look at a few details here. So when they looked at first versus second generation DES, there's actually quite a difference, numerical difference, and we don't know whether this is actually statistically significant or not. It makes sense that they actually didn't provide the numbers because the main number was not significant. But certainly numerically and visually, it appears that much better results with newer generation DES than with first generation DES, and maybe that's important for the future and for conduct of other trials to look at these kinds of numbers when we're designing and powering our trials in the future. So binary restenosis, which of course was not a primary outcome, was significantly better in the two-stent technique group than in the provisional group. Now, the authors actually concluded, or at least in their discussion stated, that they really didn't know if the relatively favorable results in the 2-stent group of Nordic Baltic 4 might have further improved using the DK crush technique. Their, I would say, proportion of patients in whom they were able to achieve final kissing balloon inflation was just over 90%, so not really the standard that we see with DK crush technique, and that might have been one of the reasons why they chose this. Again, this was, of course, study was done before DK crush really became known as a very good technique from the randomized trials by Shaoling's Nanjing group. So it is not, it can't be criticized that they didn't use that particular technique. But again, for future studies, this is important. So not everybody needs a 2-stent technique. Not everybody needs a DK crush. This was a 55-year-old lady with an acute coronary syndrome transferred to our CCU from a peripheral sister hospital lab that did not have bypass surgery. She was transferred to the CCU for bypass. I was actually in the CCU. She was had further chest pain in the unit. Surgery was planned for Monday, and I discussed the possibility of doing PCI instead, to which she agreed. And after all the usual steps and optimization, we achieved this result. Actually, that's coming here. She also had a distal lesion, significant long distal lesion, so I'm not sure that bypass actually would have been ideal for her, and had a very good result with proximal optimization and distal reentry of the side branch stent struts into the circumflex and kissing balloon inflation. Now, however, in this kind of a case, this of a 65-year-old man with severe COPD, not a great candidate for surgery, class 3 angina, a 2-stent strategy is a must. I think there's no way that we can salvage even, let alone optimize this very important circumflex side branch without placing a stent in it. So clearly what looks like a 1-1-1 bifurcation, or at least a 0-1-1 in this particular patient in a dominant with a dominant circumflex vessel. So we pre-dilated both, and I do want to go through some of the technical details of the DK crush with non-compliant balloon. In this case, sometimes you may have to start with a compliant balloon if you can't get a non-compliant balloon across. I don't think it's that important in this case, except where we have calcification. The non-compliant balloon can be, of course, taken to higher pressures and will work well. We then deployed a side branch stent. It really is like a mini crush in that I try to leave as few struts in the main vessel as possible. I'm not a believer of the nano crush because of, I think, the strong possibility of geographic miss. And the nano crush, of course, has been written about and promoted recently, but I'm not really a fan of that particular technique. So here is the placement of very few, maybe 1 or 2 struts in the main vessel. The stent is deployed, then crushed. Now, this was done a couple of years ago. Now I actually do a pot crush so that I place a balloon, actually non-compliant balloon, sized for the main vessel just at the carina, so that I actually optimize the angle of re-entry. You can do this. In this case, I actually did this in 2 steps. You can see that there is a pot happening here, but in fact, that first step is probably not entirely necessary. You can place your pot crush balloon when you're deploying your main vessel stent. have to be careful, of course, to position it correctly. It's important then when we're recrossing the side branch, the crushed struts, that we do this through non-distal cell. In this case, I actually had to go to 1.5 millimeter balloon, as a bigger balloon would not cross, but the 1.5 went easily and then dilated up. Now, why recross through non-distal stents? If you wire distally, as we do in a provisional procedure, you actually have the potential of removing the struts from the ostium at the distal aspect of at the carinal aspect of the vessel. So it's important, and I know we wrote in a recent European Bifurcation Club white paper that it should be proximal to, I would say proximal to mid, and I think that's actually how we wrote it. Important for it not to be distal. I think the mid is probably the optimal position because it avoids the possibility of bunching a lot of metal at the carina, creating a large bulky neocarina. So we then dilate the side branch, having done that, and do the kiss at this point. And then we deploy the main vessel stent. In this case, this is a 3.5 by 38 DES. And then another pot to ensure that when we're recrossing, we're not going subluminally in the main vessel. So pot to the size of the main vessel. And this would have been a 4 by 8 non-compliant balloon. And this is the result we have at this point. I didn't quite like, and today I may actually use lithotripsy, which I have available to me, perhaps even to optimize this ahead of time, or even perhaps to touch this up at this point if my non-compliant post-inflation was not adequate in this proximal ostial LAD segment. We thought we had a pretty decent result with a non-compliant balloon. We then dilated the struts and kissed again. This time it's okay to do a distal recross because we've already ensured that we have stent coverage around the entire perimeter of the ostium. And a distal recross now will, to my mind, will ensure that we don't get further bulking of the carina. So in a sense, this is like doing a provisional recrossing and stenting at this point. Imaging is important. I have to admit I don't do it in 100% of the cases. I size my vessel according to Finet's law often when I see normal segments of the branch vessels. And especially if I've used a lot of dye, I won't do OCT. In this case, this is not, I have to admit, not the best technically OCT ever, but clearly we see some malapposition in the left main. So this is further post dilated with a 4.5 by 8 millimeter non-compliant balloon at high pressures. And then we had the final result, which I think was quite nice compared to how we had started, with also good result in the circumflex, which I show here. This is now the stented segment. And you'll see coming up the bifurcation itself, which shows good stent apposition now of this stent, an excellent opening into that side branch, and no longer seeing the malapposition that we saw previously for the most part. So we now have a systematic review. looking at the DK crush versus other techniques. This was published in the Canadian Journal of Cardiology very recently by colleagues in Italy, Gabriele Crimi and colleagues, looking at a total of 26 studies, randomized trials that were done in this space. And in all of these, DK crush actually appeared to do better than other techniques when compared with each other. So again, we see DK crush versus T-stenting. This is non-significant. DK crush versus provisional, when that was tested, mostly again in the Nanjing studies from Xiaoliang Chen. And again, crushing versus DK crush. This is interesting because it's a crush, right? Let me go back to that. It's a crush versus DK crush. There's a huge difference between crush, even a mini crush and a DK crush, because even in a mini crush, we're recrossing, we're crushing the stent with another stent. And therefore you're going through multiple layers of stent struts to recross the ostium. You will never get the kind of result and the kind of opening that you get with the DK crush when you've only crossed through at most two stent layers of the crush stent versus 3 in a crush technique or even a mini crush technique. So again, this is comparing the DK crush versus provisional stenting versus all the other techniques compared with DK crush. Culotte, the DK crush stands out again. And really in all respects in this slide, we see that DK crush is superior. This was the rankings of efficacy of different stenting techniques of the device-oriented clinical events, showing that DK crush ranked #1, whereas all these other techniques were ranked, the TAP in fact is #7 of these. And I have a great concern about TAP, especially in lower angled bifurcations and in any bifurcation because of the possibility of either geographic miss or too much stent material in the left main vessel. Especially in the left main vessel, I think that's to me not optimal. So this is DK crush 5, showing again target vessel MI lower in DK crush. DK crush target lesion failure, of course, the primary endpoint was significantly different. When we look at the Kaplan-Meier curve of this, or the hazard ratio, in fact, I've seen colleagues discuss this curve as, oh, well, yeah, they did the revascularization after they did the follow-up angiogram. Well, the follow-up angiogram was, in fact, so we have to read the paper. The follow-up angiogram was scheduled at 13 months. So as the text says, if we read the paper, angiographic follow-up was completed in 158 patients, so not all patients, but these results included 32 provisional stenting and 15 DK patients who underwent elective repeat angios before 12 months for recurrent chest pain. And of these, TLR was performed in 15 provisional and 8 DK patients. So that's what this is. This is not the result of the planned angiographic follow-up, which in fact occurred here, not here. So I think we have to put that particular critique to rest. This is DK crush 3. This is, again, against the Culotte technique. In fact, this is around the time of angiographic follow-up when this separation does occur. So to summarize, I think the DK crush provides the best coverage of the side branch ostium and the best geometry of any technique when done well. The DK crush randomized trial series have shown impressive results compared to all other techniques. really we do need, and the rest of us need to study DK crush. We shouldn't have studies today done in Europe and elsewhere that do not include this particular technique when we're evaluating strategies. The question is, can the rest of us do this as well? So in Canada, we are planning and currently developing the CBC1 trial, looking exactly at this DK crush versus provisional and other techniques. Thank you.
Thank you very much, Vlad. A few questions from the audience. Let's address one from Dr. Al-Mutairi from Kuwait. Is there a bifurcation angle not suitable for DK crush?
I used to think so, and in an early publication that we did with crush techniques and culotte, we actually showed that the outcomes were better in lower angle bifurcations than in T-type bifurcations. But I'm finding that if you think about it, in a T bifurcation, if you stent the main vessel first, it's going to be more, and then you find that you have difficulty with your side branch, it's going to be much more difficult to deliver a stent into that T-angle bifurcated side branch than to deliver a balloon. So that's one reason where, and with DK crush, as opposed to the old crush or mini crush, I find that the angle is not as relevant because technically it's much easier to achieve than it would have been with a regular or even a mini crush technique. So I don't think angle is a big factor anymore.
Can you explain pot crush? Is it crush to circumference? Yeah, go ahead.
So I should have actually drawn a diagram for you, but so imagine doing so when you're doing a crush, you are putting the stent balloon partly into the left main, of course, and you're also at the same time putting a balloon, usually people say a non-compliant balloon that extends from the main branch to the left main, covering the stent that you're about to crush. So that leaves you with a crush that's actually inadequate, incomplete, because that balloon was not sized for the left main. That balloon was sized for the main branch. So you then have to follow that up with a pot of the crushed stent in the left main. But instead what I'm doing now is I'm placing my stent, I use a crush balloon that really is a main vessel balloon, a non-compliant main vessel balloon, and I position the distal marker of that balloon at the carina to ensure that I'm covering the entire stent that I'm about to crush, but not encroaching onto the main branch. And I use that balloon then in that position to crush my stent, which in that single step optimizes the crush, optimizes the angle of reentry into the side branch. So I'm essentially, if you don't do that pot step, you may actually have difficulty recrossing. You may go subluminal. With doing the pot step, you eliminate that possibility, and by doing that in just one step, you actually eliminate one step. Does that make sense?
Makes perfect sense to me. Dr. Francesco Lavara has joined us from Jilin, China, and he would like your comment about rewiring in the DK crush, whether it's proximal or as suggested otherwise by recent EBC consensus document.
Well, yes. So there are two rewirings, right? So I think as I had mentioned, the first rewiring I would say should be non-distal. Okay. So it should be concentric, it should be proximal to mid. And my preference currently is to go for mid for the reason that I explained, that it minimizes it optimizes the chance of complete stent coverage of the ostium and minimizes the risk of amassing a lot of stent material at the carina. So that's the mid. You can go proximal to mid, I think. I think Xiaoling Chen recommends proximal. I think in the paper we actually said mid to proximal or non-distal. The second recrossing can be distal. In fact, it's probably better for it not to be proximal, because if you do that recrossing proximal, then you're going to have a lot of stent material at the carina. So I think that second recrossing actually should be like our recrossing in the provisional technique.
Anyone else from the panel have any comments, as this is such an important topic with so much interest? We're not going to be able to address all the questions, of course, but if any important comments from the panel members, please feel free.
Well, actually, I think today, if you are using crash technique, DK crash is the best way to do crashing. This is out of any discussion, I think. We have so many data about DK crash and the better outcome you're having with DK crash. What is my point is DK crash, conventional DK crash described by Professor Chen, is giving optimal results. If you are adding more and more steps, this will be more challenging for not so trained operators. So I think it is good to have in mind the essential steps of DK crash, to do it step by step.
Yeah.
And whether you are adding or not, that is coming, Vlad, you have a high experience and you can do pot after crashing and so on, because this is coming from your experience. And I think it is very good thing to try to improve what you are doing every time, but should not be fixed as a fixed step in DK crash, because this will make it more challenging for less trained operator like you, like others, I mean.
But
I think,
you know, in many times, these additional steps make procedure easier, actually. If you do the pops, then everything is easier, because you are stretching the struts. It's easier to rewire, easier to deliver so sometimes those additional steps are easy per se, but they make everything easier afterwards.
Especially was what mentioned by Professor Dzavik, this pot crushing of the stent which is in the side branch. Maybe you know, when originally DK crash was developed for non-left main bifurcations, it was not so necessary, but in the left main, with this discrepancy in sizes between the distal main vessel and the proximal main vessel, if you don't crush the stent with the pot balloon, then you can get into troubles. And this is, I believe, very important. And this is something you amaze me, because I use it as an additional step. So it means that routine crash with balloon sized according to the distal main vessel, followed by pot. But for the first time, you shown me that you can skip this first one, just use the pot balloon, and maybe it's a good approach to do. And then we just replace, one balloon with another and not add additional step.
Yeah, actually, my point is not, I think for experienced operator, it is good you can add any step you see that could be appropriate to add or can improve your result. But actually, for beginners, I think this will add more steps and will make it, at least for beginners, more challenging, not difficult. Maybe you are right. I mean, these improvements will make it easier, or are done to make it easier. But for beginners, again, if you are adding more, that is why DK crash is not practiced all over the world. I mean, by beginners.
Well, Imad, it's a complex technique to begin with. So you're right. This is probably a technique for experienced operators, and probably experienced operators should be doing complex left main stenting.
Yes.
That first step I did was not, it's a replacement of a step, right? So it's essentially doing the same. It's not adding a step, it's replacing a stent. And in the case of doing the pot, after you deploy the main vessel stent, I think the pot is essential. I think it's not typically described in the techniques, but I think it's an essential step. Otherwise, you could get in trouble. And I think here, as others, Niels and Marciej have pointed out, it actually makes the procedure easier rather than more complex.
Vlad, I need to make a comment if you agree and if you accept. We learned from the visible heart how important is to properly crush.
Yeah.
Because if you crush with the main vessel size balloon, in that case, you really have high likelihood of crossing through the true lumen instead of crossing aside.
Yeah.
We really discussed that issue with Shaoliang Chen, and as far as I know, this step is now integral part of the DK crush that he recommends himself.
Yeah, so I actually went to Minneapolis and I did the Living Heart DK crush, and I haven't got my images yet, but I'm going to ask the folks there to actually provide those for me so I could share them with you at a later time. But we had a wonderful experience there in Minneapolis at the University of Minnesota with the Living Heart, and really demonstrated the benefits of this.
Yeah, and
you can also check this in vivo. Just, perform your crushing with the balloon, which is sized according to LAD diameter, and then do the IVUS pullback in the left line.
Yeah. Good point. Good.
Sometimes it's more than 1 millimeter of mala position.
Yeah. One more comment for my friend Imad Sheiban. I'm sure you know that for operators to be selected to participate in DK Crush 5, operators had to provide 5 successful cases of DK Crush. So this is just to strengthen that this technique is complex and it should be really reserved for experienced people and not for the beginners. Yeah,
that's my point. Yeah, that's why I did my comment. I think it is for experienced operator. Yeah.
Excellent technique, but for experienced people.
Great comments. Thank you very much. That's a perfect segue into the next topic. We need to have other techniques besides the DK crush. So now it's a privilege to have Dr. Imad Sheiban from Verona, Italy, and also course co-director of the C3 meeting. He will now discuss culotte technique is still a good alternative in bifurcation.
Okay, thank you, Raj. It's really a pleasure being here with you and all the panelists. I think it is great discussions as usual, and great learning also for everybody. So, culotte technique, I think these are the most frequently used techniques today for bifurcation stenting.
Imad, we're not seeing your slides.
You are not seeing?
I'm not. Anybody else see them?
I will try to. You are seeing now?
Yes, you can.
Okay. Sorry for that.
That's okay.
So, the most frequently used two-stent technique in bifurcation lesions today are T protrusion, tap, culotte technique, and crush, mini crush, or DK crush. So crush, culotte, and modified T and modified T. For the culotte technique, I think we have some pros. Can be used as a provisional bifurcation strategy, is adaptable to varying angles between LAD and circumflex. If you are treating distal left main, ensures complete lesion coverage with some exception, of course. And of course, access to main vessel side branch can be lost during stent implantation with potential not to be able to re-enter, but this is for any two stents techniques. In distal left main, often too large for the most drug-eluting stents diameters, so the position of the stent in main vessel in main branch left main is not ensured. Relatively vessel in main branch left main is not relatively few drug-eluting stents with proven low restenosis with struts can be used, can be opened more than 3.5 millimeters. But I think today we have more than one. If we start with bench testing, then this study done in 2013 and was taking consideration conventional crush against culotte, T-stenting, and tap. And the conclusion from this is in this model, the crush technique resulted in a higher wrist malapposition than either of the culotte and or T or tap techniques. If we go for clinical study, then this is crush versus culotte stenting. And this is showing that, again, this is crush, conventional crush, not decay crush. And you see that culotte is superior here than conventional crush. This is another randomized comparison that me coming from Nordic stent technique study. And again, showing that crush, conventional, not decay crush, I underline that, is doing, culotte is doing better than crush also in this study. Now, culotte and tap, this is was compared in one study and showing that raised stenosis on side branch is significantly higher if we are using tap as compared to culotte stenting. And again, this is a systematic review meta-analysis of clinical trials, including crush versus culotte, including crush, any type of crush. That means also decay crush study are included here, but not only, versus culotte stenting. And if you see that there is some parameter or let's say MACE favoring crush technique, and this is regarding stent thrombosis, which is significantly lower in crush as compared to culotte, but other parameters are similar. That means no significant difference except for stent thrombosis. And this was the conclusion from this meta-analysis. In the treatment of coronary bifurcation lesion, target lesion and MACE are not significantly different between crush and the culotte groups, but target lesion and MACE were also regarded as high heterogeneity, mainly due to better outcomes achieved by decay crush, and there was a trend toward lower stent thrombosis in the crush group. Crush, particularly decay crush, may be superior to conventional culotte for treatment of coronary bifurcation lesion. I would like to underline again also conventional culotte, because I think today conventional culotte can be improved very significantly, and this also might be translated in a better clinical outcome. This is coming from the Shaolian Shen group, clinical, this is the decay crush 3 study, which was mentioned previously by Vlad, and showing the superiority of decay crush against culotte. But culotte here was conventional, again, was not modified culotte. So what are the limitations of culotte technique? Well, struts cannot be fully opposed to the vessel wall. Side branch stent is undersized, smaller than main branch, and often overstretched and not matching the main vessel size, limit of expansion. multiple layers opposed to main branch, and this might predispose for stent thrombosis. Well, I think bench data are known for everybody, showing these limitations in culotte technique, as well as inappropriate rewiring might produce some damage, which cannot be anymore corrected if you are crossing outside and with re-entry inside the stent when you are doing your final steps, that mean kissing balloon. So the question today can be if the culotte technique can be improved and optimized. I think yes, because stent design and selection are much better today, and we have much more possibility than previously. Stent apposition and expansion, we learned much more about. POT also was introduced, and now it's much more popular. Kissing balloon inflation, appropriate kissing balloon inflation is done more and more in two stents strategies. Appropriate stent crossing with guide wire, we learned much more today than previously, and intravascular imaging, of course, can help. What is important to know that if you are doing culotte technique, I think you should know what you are using, which stent you are using, the design of the stent, how much you can open your strut without deformation of the stent outside, and how much shortening you might have if you are overexpanding your stent too much, as the mismatch between the side branch and main vessel is almost very frequent. The technique, culotte technique, as was described previously, recently, you see that some step was added, like the POT after side branch stenting. The POT in proximal, in the segment of the stent protruding in main vessel, POT is recommended as a new step in culotte stenting as compared to conventional stent. And what I'll show you now, just how to do it, it is important to follow step by step every time, as in any two stent techniques, as have been shown also for DK crush by Vlad previously. So this is a case with complex bifurcation, indication for two-stent strategy. We went for culotte technique. Well, first step, wire the branches. Second step, pre-dilatation and lesion preparation. That means if you need rota or any debulking device, you should use it to prepare very appropriately the lesion before putting any stent. Third step will be the delivery of the stent in side branch, in crossover to main vessel. And again, try to protrude as less as possible in main vessel from side branch stent, with the side branch stent. I tried here in this case to protrude with two or three struts, not more. And I show you that this was possible, as can be demonstrated by stent boost or stent enhancement. Then the fourth step is before rewiring or crossing the stent, then you should do a POT to side branch stent in main vessel. And this is what was added, as I show you before, to culotte stenting. And this should be what is named the first POT. And after this, you can see that the stent in main vessel is appropriately expanded and opposed to the main vessel. Then it is more easy to cross, and here you should cross distally in order to have more appropriate coverage of the ostium of main vessel, distal main vessel, and remove the step 5 and 6, remove the gel wire, rewire main vessel through the distal part, the distal part on the ostium, on the distal segment of main vessel. And 7-step strut dilatation to main vessel with one balloon to distal main vessel diameter. And you see here that if what can happen if you are opening the strut with large balloon, this might deform the stent and can give you some malapposition of the stent on the opposite side of where you are dilating the strut. And of course, at this point, what I do is doing first kissing balloon in order to be sure that even if this will be occurring, will be corrected by kissing balloon inflation. I'm kissing balloon inflation with non-compliant balloon, side branch, and distal main vessel sized as 1-to-1 balloon. This after kissing balloon, and what schematically I can show you, this is what can be seen easily by stent enhancement. You can have your completely open and expanded segment of the stent opened in main vessel, protruded in main vessel. And here on side branch, you will have completely opposed and completely covered ostium of side branch with no stent deformation or with very good opposition on the coverage of the ostium. And then at this point, you're ready to go with your stent to main vessel, like ninth step. And after this, you see this is the angio, and this is the stent boost showing good expansion, but still having some under expansion at the carina here, at the distal part of left main, and but you don't have any deformation of the stent on side branch. Side branch ostium is still well covered with the stent, and the stent is well opposed to the ostium as well. The stent exchange wire, complete as usually culotte technique, second kissing balloon inflation, and final port, second port, final port. And this will be the final stent boost, showing exactly very good opposition, very good coverage of the ostium, and very good expansion of the stent on both branches without any deformation. And even you can see how many struts are overlapped. And here still you can see exactly that you have only 2 struts overlapped with the 2 stents. And of course, intravascular imaging should be done, or should guide your optimization. And this is the final IVUS. You can see exactly everything in place. Stents are very well expanded. Here, both ostium on the carina are well expanded, the stent well expanded, both ostium are covered. And this, again, if you have OCT, that might give you more and more details. You can see exactly if you have still having some strut on the ostium of side branch. After you can see also the expansion of the segment protruding in main vessel after part of side branch stent in main vessel, and you can see exactly how with the complete details, the expansion and the coverage of the ostium of side branch. And here again, you see the carina after stenting with details, with no stent fractures, no damage on the stent, very good expansion, and very good final result, as you can see here with this final angio. So my final remarks is culotte technique is technically demanding as any 2 stents technique, and particularly if you need more steps, is demanding and need expertise. It can routinely be applied in left main bifurcation. Given the availability of large drug-eluting stent diameter, today we have till 4 stent that can open till 4.5 or 5 millimeters. In the modern approach to bifurcation lesion, many limitations of culotte technique can be overcome or eliminated, which likely can improve clinical outcome and confer to culotte approach an important role as a good alternative, particularly in distal left main interventions. Thank you very much for your attention.
Thanks, Imad, for that great presentation. Let's ask panel members to make some comments. I have noticed recently in Eurointervention, Dr. Toth and his colleagues wrote about optimization of culotte. Gabor is still with us. Gabor, do you have any comments?
Yeah, thanks a lot. I just wanted to say I really like what you mentioned about doing the kissing twice. And I think it's indeed an important issue. And if you don't mind, I would like to share 2 images from bench testing, which can burn into your mind, and then you will do double kissing all the time when you do culotte.
Sure.
Sure.
Second.
I have to stop sharing, right?
Yeah, I think.
Okay. Go.
It looks like Goran is sharing the screen now.
Goran, you are sharing the screen.
Yeah.
You should
do.
Yeah.
If you just stop sharing the screen for 1 minute, we'll be able to see Dr. Toth's slides. Okay, perhaps not a good idea.
Look at this.
Okay. I see now.
Good.
Yeah.
Good. So this is how it looks first when you open up the side branch. Open up the side branch only, and then you put your stent in there, and look what happens with the ostium of the other branch. Massive deformation, and you can easily imagine that it will be very difficult to properly rewire this branch afterwards.
Absolutely.
While you do a kissing first, yeah, there is nothing in the balloon, so you just see how it deforms. You do a kissing first, and then put a stent. It doesn't move at all. So you have perfect result, maintained result in the ostium, meaning that it will be easy to rewire. So I would ask the colleagues who follow this webinar to remind this image, if we go one back, how hopefully it can look if you just open up the branch towards the side cell without doing a kiss before, and you can be sure that this predicts already a very bad outcome afterwards, or a bad result after the stenting.
Yeah, that is why I think that culotte studies done with conventional culotte, that means without double kissing, were given a bad clinical outcome. That means we were inferior to what you were compared to.
Yep.
So I think it is very important today in the modern era of bifurcation stenting. I think, yeah, some improvement can be done and should be done. We have adequate, also appropriate stent to use for this technique. So I think all these limitations can be corrected, or in some cases can be also eliminated as well. And I think if we now compare modified, let's say modified, I'm not introducing any new approach for bifurcation, it's culotte, but optimized culotte, let's say, I think the outcome will be different if you are compared to crush or tap or other techniques.
Yeah, I agree with you. I think the advantage of DK crush as compared to crush is the same story. A perfectly performed crush is just as perfect as a perfect DK crush.
Exactly.
If you do DK, then the chance to have a perfect result is higher than if you just go for crush, because then there are some unpredictable steps.
Exactly, yeah.
Well, thank you very much, everyone. And now it's a privilege to have Professor Goran Stankovic, who is course co-director of the bifurcation session of C3. It's a great contributor to the science of bifurcation. He serves as professor of medicine at Belgrade University, and also he's the director of invasive cardiology at Clinical Center of Serbia in Serbia. So it's an honor to have you, Goran. Thank you again for your incredible work in this area and all your help in arranging EBC and C3's ongoing association, which is resulted into a tremendous impact on the bifurcation education in the world. So thanks again for being part of it, and floor is off to you now to talk about provisional stenting remains the reference technique.
Thank you very much, Raj, and thank you very much after the last week for giving me opportunity to share really my philosophy of bifurcation PCI, because I believe that we should join forces and we should work on both sides of the Atlantic. And these are all our efforts in the last couple of years. And I would like to thank also Ramesh Daggubati for helping me connect EBC with Sky as well, because I think world is very small and we really need to share knowledge, experience, and practice. So provisional stenting as the reference technique, I don't have any conflict of interest to share. And if we go to the latest guidelines of the European Society of Cardiology, provisional is really recommended with class 1 level of evidence A for bifurcations, and except for small note for the left main in which decay crash may have preference over the provisional. What we have so far is at least 11 randomized studies with drug-eluting stents comparing 1 versus systematic 2-stent strategy. And we also have at least 8 meta-analyses. And as a result, there is no advantage in using systematic 2-stent strategy, and stepwise provisional T should be the gold standard for most bifurcation lesions. But of course, this does not mean there are no occasions when 2-stent strategy is required. And now we have also data from Decay Crash 5 and Definition 2 studies. And I have to say something that we did not hear in previous presentations. The mean length of the circumflex lesion in Decay Crash 5 was 16 millimeters. And the mean length of the side branch lesion in Definition 2 is 19 millimeters. I don't think that anybody believes that these are lesions which could be safely treated with single stent strategy and just with balloon dilatation. Show results of Decay Crash 5 and Definition 2 are not unexpected, but I think we should use those results properly, and we should recommend systematic 2 stents for lesions enrolled in those 2 studies. What is relevant for our practice is to follow our patients for a longer period of time. And this is a 5-year survival from individual patient level pool analysis of Nordic and BBC1. And as you may see with time, more metal produces worse outcome. So at 5 years of follow-up, all-cause mortality was significantly higher with 2 stents compared to 1 stent. And even longer term follow-up shows that curves continue to diverge. And Nordic bifurcation study at 10 years of follow-up individually showed higher risk of all-cause mortality with more metal, with 2-stent technique compared to provisional strategy. If we go to real world, I would like to point the presentation of Patrick Serroyos from the Global Leaders Trial at European Bifurcation Club meeting 2 years ago, and he analyzed outcome in the real world treatment of 2,510 bifurcations, and he showed that 2 or more stents compared with single stent with provisional at 2 years of follow-up show higher rate of target vessel revascularization, but what is even more important, significantly higher rate of definite or probable stent thrombosis And those are probably the lesions which may potentially benefit from stronger antiplatelet regimen. A recent meta-analysis of 9 randomized trials with 3,265 patients who were followed for at least 3 years showed very important findings for today's discussion. The primary outcome of this analysis was all-cause mortality, and secondary outcomes were myocardial infarction, definite and probable stent thrombosis, TLR, and MACE. And it's important to see that there are also DK Crash 5 and DK Crash 2 studies included. This is the primary outcome, all-cause mortality at 3 years of follow-up, and you may see that there is significantly lower total mortality at 3 years follow-up in these 9 studies comparing 1 versus planned 2-stent strategy with 31% relative risk reduction with provisional at 3 years of follow-up. Secondary outcomes, MACE, myocardial infarction, target lesion revascularization, and stent thrombosis were not different between 2 strategies. But in 5 studies with total of 1,713 patients who provided even longer than 3 years clinical follow-up, the mean follow-up was 4.7 years, clearly showed that longer-term follow-up provides consistent and even higher relative risk mortality reduction, and there is 37% relative risk reduction with provisional compared to planned systematic 2-stent strategy. However, our topic today is left main, and we should discuss the optimal stenting strategy in left main and discuss the evidence that we have for the long-term outcome of 1 versus 2 stents in the left main. And I will start with Italian registry with 773 distal left main bifurcations treated in Italy with various techniques, and 2-year clinical outcome was compared between provisional and 2-stent strategy. And as you may clearly see, there was no difference in survival. There was no difference in survival from cardiac mortality. There was no difference in survival from myocardial infarction. However, there was significantly higher rate of target lesion revascularization as expected with planned 2-stent strategy. But what is relevant from this paper is also propensity-adjusted Cox regression analysis of the risk of 2-year cardiac mortality and MI, and you can clearly see that in propensity-adjusted analysis, there is a higher rate of cardiac mortality and MI if we use systematic 2 stents compared to provisional. And similar data were confirmed at 3 years outcome in the J-Cipher registry, and in that study published by Toifoku in Circulation 2009, cardiac mortality as well as target lesion revascularization was clearly higher with 2 stents compared to provisional. Another more recent study from Aoi registry from Japan also showed in 1,318 patients with bifurcations that bifurcation study has impact. And in that registry, 999 patients were treated with provisional stenting and 282 patients with 2-stent strategy. Non-bifurcation ostial or proximal mid left main was present in 219 patients. At 4.6 years of clinical follow-up, what we learn from this large registry is that 2-stent strategy is associated with worse clinical outcomes, high rate of target lesion revascularization, but also again, definite or probable stent thrombosis was higher, and there was no difference in all-cause mortality. So we confirm, of course, higher risk for target lesion revascularization and target lesion failure in total. But again, authors performed very important landmark analysis comparing the outcomes within the first year and after the first year of follow-up. And what is important is that within the first year, TLR and stent thrombosis rate of two-stent strategy were higher in those with provisional, and after the in two stents compared to provisional, but after the first year, there was no difference in outcome between two stent and one stent strategy. And the latest article that I want to comment is technique analysis from the Excel. And in that study, published by David Kanzari and co-authors in the Circ Interventions 2018, that study showed that 3-year adverse outcomes were worse again in planned two-stent treatment compared with provisional. And I was invited to write editorial, and I put in accordance with EBC consensus that we should really select proper technique for individual patient. You see here a difference in death MI, hard endpoints, death MI, and stroke, with clear difference between provisional compared to two-stent strategy. And even if we add ischemia-driven revascularization, on top we have P 0.07, so almost reach statistical significance. So based on all this evidence, in the latest EBC consensus on left main PCI techniques, the lead author was Francesco Burzotta. What we put as a final comment based on the available evidence is that when planned two-stent strategy is used, this should be done in provisional stepwise approach, finalizing procedure when needed with T, TAP, or culotte technique as a crossover from the provisional. However, having the evidence from DK Crash 5, we also accept that for operators with the appropriate experience, double kissing crash is a valuable option, but for complex left main bifurcation disease. And I will just show one of my cases to illustrate that provisional as a strategy could be used also in complex anatomy. This is ACS patient, female patient, no risk factors, troponin positive, right coronary artery showing collaterals towards the left. And this is baseline angiogram of the left coronary artery. So when you see this anatomy, I guess that most of the people will try to understand first where is the exact plaque distribution, and then decide on the strategy. This is a lumen contour, this is a vessel contour. So in my view, if we look at this, although complex and geographic appearance, we can clearly understand that most of the plaque is actually in the lateral wall in front of the ostium of the LAD. So in my view, using a single stent from the left main into the LAD, we will be able to compress this plaque, having circumflex ostium and ostium of the first marginal branch not severely affected. So my strategy was provisional from left main to the LAD and then kissing towards the circ. So it was difficult to wire, and I had to use venture monorail and several guide wires. Finally, with whisper light support, I was able to go into the LAD. And then more or less we continue with standard provisional strategy. So 3 wires in all 3 branches, pre-dilatation only towards the left main LAD. After that, stenting and stent positioning to cover, because of the short and diffuse disease, from the ostium of the left main. This is the result. After stenting, we see some combination, of course, of carina and huge plaque shift towards the circ. After the pot, result improved already at the ostium of the circ. And after exchanging the wire, I used 3 balloons and I did tracing. And this is the result after tracing and the final result of the procedure. So even in complex anatomy of the left main, we should consider plaque distribution and plan our strategy based on, of course, individual patient clinical presentation. However, what we need to wait is EBC main study results. This is European Bifurcation Club left main study, randomized comparison of single versus dual stenting for true distal left main coronary lesions. Our hypothesis is that planned provisional single stent strategy rather than plan dual stent strategy should improve clinical result in true distal left main bifurcations. I'm happy to share with you that on 1st December last year, we completed recruitment, and I would like to congratulate to people who really did great work and enroll the patients, and we need to wait for February or March next year in order to present final result and maybe add to excellent results achieved in DK Crash 5. So dear colleagues and friends, I would like to conclude that compared with single stenting, double stenting in left main is associated with significantly higher long-term risk of MACE and in some studies also with long-term risk of all-cause mortality. Higher incidence of target lesion revascularization is present with two stents, whereas the risk of cardiac mortality, MI, and stent thrombosis is usually similar. A randomized ongoing EBC main should give us part of the evidence coming from the Europe and compare that one with DK Crash 5, but I'm really happy and convinced to conclude that provisional sideburn stenting approach is recommended also for the left main treatment in most cases. I thank you very much for your attention.
Thank you very much, Goran, for the great presentation. Any comments from the panel members?
I would like to underline again that, of course, most of cases have a simple bifurcation in distal left main also. And these patients, of course, I fully agree with Goran, provisional stenting is the default strategy in these patients. But you should agree with me, Goran, that we have at least 10, 15, even 20% of cases with complex lesions, with long lesion on side branch, that mean more than 10 millimeters, that you should start with your two-stent strategy as default strategy. Because otherwise, as you have shown, the same meta-analysis you have shown by Ford, he was showing that if you are shifting from provisional to provisional two stents, then the outcome will be worse. That means MACE will be increased as compared to two stents as default strategy. That means starting with two stents immediately, not shifting from provisional. So I think this is very important to agree on, because otherwise we still having some confusion. Where I have to do provisional, where I have to do two stents, and so on.
Imad, I fully agree with the part of the complexity that you define, but you know, people also need to understand that complexity is really more than 10 millimeters. In DK Crash 5, it's 16.7, so 17 millimeter long disease in the circ, in the large circ. And you just dilate and you leave it dissected, or you don't even dilate and you do TLR at follow-up. Of course, 47% crossover for me is low. So this is not the patient subset to test 1 versus 2. You should test 2 versus 2 and then report. So we have agreement. I just would like to point that I attended several meetings worldwide, and then I saw many live cases. And in one case, in big meeting in Asia, there was 001 ostial circ. And then strategy was DK Crash. And I why DK Crash? And they said it's in the guidelines. You know, I'm just trying to prevent that kind of decision making. It's in the guidelines. So what you define as complex is large, diffusely diseased circ. And then if you have experience, I fully agree, DK Crash is great.
Goran, if I could make a couple of comments, great presentation. I think the meta-analyses that you mentioned, you know, are heavily weighed by two studies, BBC1 and Nordic, you know, which were great studies when they were done, but studies done A, with first generation drug-eluting stents, and B, in both studies, 25% of patients who had the two-stent technique did not have a final kissing balloon inflation. So if you leave struts over ostia of complexly treated bifurcations, I'm not surprised that you would have worse outcome in those patients. Nordic 4, the second point is about the lesion length. So unlike DK5 Crush 5 and DK Crush 3 and most of the left main studies from Nanjing, where the lesion length was in the teens, 15, 16, you're absolutely right. In Nordic 4, which was just published, the side branch lesion length was under 10 millimeters. It was about 6.8, as I recall. So even in that case, even though that was called a negative trial, all the numbers went in the direction, including hard outcomes, in the direction of the two-stent techniques. And I would say about that study, the only thing you can say is you can't make the conclusion that there was no benefit. There were trends, and the study was underpowered. At 450 patients, the study was underpowered to test the hard outcomes that they were testing. There was a significant benefit in terms of in-stent restenosis for the two-stent group. And this is a lesion length of 6.8 millimeters. So I think those are the only two comments I would make. The other one is that if you look at the analysis from Nordic Baltic 4 in terms of first generation versus second generation stents, and the first generation, again, were used in BBC 1 and Nordic 1, that there was markedly better outcome numerically. We don't know about p-values, but numerically with second generation, thinner struts, et cetera, than with the first generation stents. So I think we have to take those caveats into account.
No, sure, but I really need to answer to this one, Vlad. I'm really sorry. You know, first, Nordic 4 was published almost 10 years after completion in open access journal. And what we are discussing clinical studies like the Excel, which is published just recently with the most contemporary techniques used. And also in that study, I have to say, it's very difficult to do and comment sub-analysis from negative study. And if you look article in Eurointervention from the Excel on the importance of final kissing, what they found in the Excel, please go and read. They found that kissing has no impact both in provisional as well as in two-stent techniques. And I don't think that we can do this kind of slicing and using part of the evidence from this or the other study. We should make a general discussion and speak what Imad described well, complex lesion versus other lesions, and then define strategy according to overall anatomical presentation. Not in this study is this, in this study is that.
Yeah, I would agree with that, Goran. But to say that Excel was not designed to answer these questions, and
yeah, but neither Nordic or BBC. Yeah,
sorry,
neither Nordic or BBC. In Nordic or BBC, they performed the two-stent strategy in 50% of non-true bifurcations, you know. So it's very difficult if we cut slices in the first generation stents, in the first generation of bifurcation studies, and then try to apply that knowledge 15 years later in contemporary practice.
But both those are the studies we're still citing in terms of evidence for, you know, from meta-analyses. So that's all I'm saying. Yes, we need new studies. There's no question with new generation stents designed specifically to answer these questions.
Well, at this comment, we're gonna have to leave, and we're gonna continue now. Thanks, guys. Now it's a privilege to invite Dr. Sudhir Rathore. from Parkside, Fromley in UK to do the last presentation of today about drug-eluting balloon for the side branch treatment in 2020, when and how.
Thank you, Raj. Can you hear me, guys?
I hear you great.
And thank you very much for
I
the
just need you to go to
invitation.
the slideshow.
Thank you, guys, for the invitation, and also all the co-chairpersons. Thank you very much. So
There's
obviously,
a lot of patient privacy issues that I'm seeing here.
So we had a great discussion about variety of different things here. Obviously, majority of the patients can be treated with provisional approach, and two stents required in some cases. Now, my talk is drug-eluting balloon for side branch treatment in 2020.
Sorry, if I might interrupt for a second, can you select your presentation, your PowerPoint presentation, because we're seeing your entire desktop.
Right, okay, sorry. So I am screen sharing, and I can
go to the slideshow.
Yes, I have gone to the slideshow. It is showing slideshow on my.
But you're
share
not,
this.
I don't
share
think
the screen.
you selected your PowerPoint.
Come back in.
Mac. Can you what? Right. Okay. Let me
You share the screen.
Yes, share the screen.
But you need to select the PowerPoint.
Yeah, the PowerPoint. Select it. Open it.
Select the PowerPoint.
Perhaps turn off your presentation and turn it on again. Start it again.
Yeah, double click on that slide. There
Yeah.
you are.
Yes.
Thank you. Yeah.
Here we are. Yeah.
No.
No, not now.
Not now. Can you see now?
Why don't you stop sharing first?
Okay. Stop sharing. Share again.
And select your PowerPoint.
But I think that your presentation is already open, and you select, you know, the rank. You have to look for your open presentation, because you must have it somewhere in the background open.
My presentation now?
No.
No.
I think what Gabor said is absolutely correct. You know,
Right.
once you go to the share screen, it's ask you to open whichever PowerPoint you want to share.
Before sharing screen, open PowerPoint on your screen and then share the screen.
That is correct. Yeah.
Right. Sorry, I'm so sorry about this, guys. So now, share screen. Can you see now?
No, not yet. Okay, now
Yes.
we see.
Yes.
Now we see. Okay, now you go to slideshow.
Slideshow is not playing. Yeah.
Okay, that's it. That's it. You got it.
Okay, I'm so sorry. So so my presentation is on role of drug-eluting balloon for side branch treatment, and if we can have some better outcomes with both provisional strategy and with complex bifurcation lesion. Now, as you can see here, the bifurcation lesions are very common, seen in about 15 to 20% of the population. And if you see, the side branch is involved in about 85% of the bifurcation lesions. Now we can go, I don't want to go too much detail into the flow patterns and distribution of atherosclerotic plaque, which is more in the bifurcation ostium, and the carina is free of the disease. Now we have got several technologies available now to assess the impact of the bifurcation, whether you need to treat or not treat. You can assess them non-invasively by fractional myocardial mass and myocardial mass at risk, because most of the investigations and the studies have shown if there is at least 10% or more myocardial mass is supplied by the branch, there is a prognostic benefit to it, and it is worth protecting and treating that branch. And if you look at most of the majority of the left main bifurcation, 90% of them have more than 10% myocardial mass supplied. And if you look at non-left main bifurcation, around 20% of the side branches have more than 10% of the myocardial mass supplied. And majority of them are proximal diagonal LADs and diagonals, and the large circumflex and obtuse marginal lesions. Now, several meta-analyses have been discussed today. I will just going to point on to one of these analyses which looked at provisional versus 2 stent, and this showed better outcomes in terms of myocardial infarction with the odds ratio of 1.5 and stent thrombosis with single stent as compared to 2 stent strategy. And this includes quite a lot of randomized controlled trials and some non-randomized observational studies. And if you look at the target vessel revascularization was similar between single stent and double stent for complex bifurcation lesions. Now, Goran has also discussed 1 or 2 randomized trials and meta-analysis which are more recent, which has shown more or less similar outcomes, and the mortality was same. Now let's, if you look at now some other like DK Crush 2 and mainly DK Crush 5, which looked at left main provisional versus 2 stent strategy, which is DK Crush technique. If you look at the outcomes, the cardiac death and the target vessel MI was, so basically the cardiac death was more or less similar. Target vessel MI was a little bit better with the provisional stenting, but mainly it is driven by target lesion revascularization. So TLR rates were significantly higher in this trial with provisional stenting as compared to DK Crush. Now, if you look at in more detail what happened in DK Crush in the provisional stenting or single stenting strategy, about 47% of the patient needed side branch stenting, and Kissel balloon dilatation was done at 78%, and majority of the restenosis was at the side branch in provisional arm. Now, if you look at this, there's a trial, definition 2 trial, which also looked at simple strategy versus DK Crush strategy in complex bifurcation lesion, only recently published. If you look at this trial showed more MI in provisional group, but most of these are driven by periprocedural MI. You look at 7 versus 19. And if you look at 1 year, the target vessel revascularization was significantly higher in provisional group as compared to 2 stent group. So if you summarize the data of bifurcation studies, what it shows is the earlier studies have shown better outcomes with provisional approach. But some of the later studies involving DK Crush 5 and definition trial have shown better outcomes with 2 stent strategy, that is DK Crush technique specifically, as compared to provisional approach. But if you look in these studies, both these definition study and DK5, there was higher bailout stenting to the side branch, about 40%. And there was the MI rate was mainly driven by periprocedural MI. No difference in mortality seen, and low kissing balloon dilatation and side branch dilatation done in provisional approach. So there is still some room for improvement in the provisional arm in these studies. So there comes the role for drug-coated balloon in bifurcation PCI. If you see, several studies have been done going on from debut registry, PEPCAT trials, and all these registries, although they are small in number, they have shown good feasibility of drug-coated balloon for the side branch lesion with the drug-eluting stent in the main branch. And they have also shown lesser late loss at the side branch and less restenosis at the side branch ostium. This is again another study, International Drug-Coated Balloon Registry, which has shown good outcome with DCB only strategy and combination of DCG, DCB plus drug-eluting stent strategy. And if you look at the angiographic outcome, the majority of the binary restenosis at the side branch. So if you look at the provisional strategy and the two-stent strategy, the results are mainly driven by side branch restenosis. If we can improve the outcomes on the side branch, then maybe the outcomes with provisional strategy will also get much better. These are some of the studies looking at the restenosis after the bifurcation stenting, and these studies shows good outcomes with drug-coated balloon in the setting of restenosis after bifurcation stenting with 2 stents. As you can see here, the target vessel revascularization and cardiovascular mortality was similar or even better with the drug-coated balloon in the setting of left main bifurcation in stent restenosis. So what I would like to say that a summary of DCB data shows that the drug-coated balloon is feasible in side branch treatment. It has shown reduced side branch restenosis and TLR rates. There is a potential of significantly reduced MACE events, specifically in provisional approach and also in simple and complex bifurcation lesions. Shorter DAPT can be used in these cases, and there is no class effect seen. So I will just show you now a couple of cases here. If you see, this is a ST elevation MI case to the LAD. After dilating the LAD, there was a significant side branch, which after the stenting, it was significantly pitched. Although it was smaller in diameter, but it was quite long, and most likely it was supplying more than 10% of myocardial mass. So we went ahead and treated this in provisional fashion and treated this side branch with a drug-coated balloon. I used Magic Touch balloon here, 2.25 by 15 millimeter, followed by kissing balloon and report. And this was the final result. As you can see, the side branch is open with residual stenosis at the side branch less than 50%. And I brought this patient back in 6 months' time, and this is the result at 6 months. You can see the side branch looks quite healthy, and the side branch ostium shows no restenosis and still open. Another case I will share with you, this is a left circumflex 011 Medina classification with significant 70% stenosis after stenting the main vessel, which I stented from proximal circumflex into the AV circumflex. Now, easily in this patient, we can use 2-stent strategy as well upstream, or we can turn into a culotte. But I decided to treat this side branch with a drug-coated balloon. And after drug-coated balloon, I did a report, kissing balloon and a report. And this was the final result. You can see the side branch result is very good with no residual stenosis. And I brought this patient back in 3 months' time. And you can see here, the side branch result is holding very good with no restenosis at the side branch ostium. Another case I would like to show you, the left main stem, which has got ostial left main stem and LAD stenosis with the ostial circumflex. So I treated this with crossover left main to LAD stent, and followed by dilating the side branch into the circumflex, treating the side branch with drug-coated balloon, and then following with kissing balloon dilatation, and doing a pot and repot. And this was the final result. As you can see here, we achieved a pretty good result with no significant residual stenosis. And I got this patient back in 6-month follow-up. As you can see here, the results are holding nicely with no side branch restenosis, and the main branch result looks good. And this is my last case. This is a left main trifurcation. You can see here, significant lesion in the left main body involving the intermediate ostial LAD and the ostial circumflex. So I decided to treat this as a provisional strategy and then see how the side branch looks like. So this was the result after the left main into LAD stenting. There was more than 50% stenosis at the ostium of the left circumflex, which has got a high obtuse marginal or intermediate vessel. I decided to rewire it and treat both the branches, intermediate and the left circumflex, with a drug-coated balloon. So I treated them both with a significant the 1-to-1 size drug-coated balloon. As you can see here, first to the intermediate and then to the obtuse marginal, followed by a kissing balloon, which is a three balloon kissing balloon, followed by a report. And this was the final result I achieved here. and there's another picture here. So it's a good result in both the side branches. You can see here, easily you can convert this patient into a two-stent strategy. There was no residual dissection, so I was happy with the result. I don't have a follow-up angiogram with this, but I'm planning to bring him back in 6 months' time. So coming on to drug-coated balloon has got important role to play in some of these complex lesions, specifically in provisional stenting, but also in complex coronary lesions. And there are several balloons which are available. As you can see here, most of them are paclitaxel eluting balloon, but we have now got some sirolimus eluting balloon as well, magic touch balloon, which could be used, which has got different pharmacokinetics. You can see these here, first generation, second generation, and second generation drug eluting balloon. The technology is improving, the drug elution is improving, and the other factor I think which is most important for the use of drug-coated balloon is the preparation of the lesion. You can see here the lesion should be well prepared and it shouldn't be over dilated to prevent dissection. So the non-compliant balloon can be used at low pressures, and then cutting balloon and scoring balloon can be used in some cases along with rotational atherectomy to prepare the lesion well so the drug can go into the vessel wall and give you best result. Because most of the if you see the provisional stenting group, the side branch have been treated very aggressively, and then they had a bailout stenting in about 20% cases, and up to 30% cases bailout stenting. But if you look at drug-coated balloon data from non-bifurcation lesion, the bailout stenting is about 10 to 15% only for a flow-limiting dissection. So you need to avoid dissection if possible by better preparation of the lesion. And then that drug-coated balloon technology is also improving. As you can see, nanoparticle coatings are coming up. Better excipients and carriers of the drug-coated balloon also give better results. And obviously, newer drugs are coming on now. So my approach nowadays, what it is I use a drug-coated balloon in a lot of cases. So if there is a large bifurcation branch, more than 2.5 millimeter, I wire both the branches, dilate the main vessel as per EBC guidance, and do the drug eluting stent followed by pot, and then reassess my side branch. For non-left main stem, if the side branch is residual stenosis more than 70%, or for the left main stem more than 50%, and TIMI flow is 3, no residual dissection, I will treat them with a drug-coated balloon, recross and treat them with drug-coated balloon after the repot. And if I have to do the scoring balloon, I use the scoring balloon sometimes after putting the stent as well. And I mainly use drug-coated balloon after putting the main vessel stenting. And I found it to be safe. And some of the studies have found to be safe. And there's no problem in crossing with the drug-coated balloon and followed by repot. If in certain cases, if the side branch has got more than 70% residual stenosis or there's a flow-limiting dissection, then I convert them into a two-stent strategy, which obviously the options are tap, T, and reverse crush. But majority of the cases, I would try to not put the second stent if the flow is not reduced less than TIMI 3. So in conclusion, I would like to say the drug-coated balloon to the side branch with provisional stenting is an attractive option and is gaining ground. A lot of feasibility studies have been done, allows good drug application and restoration of the bifurcation and carina, and this drug, because if you do a bailout stenting in provisional approach, if you do T stenting or TAP, either you hang the stent too much into the main vessel or you miss the ostium. That's why the outcomes are not very good. Optimized side branch preparation in true bifurcation lesion and drug-coated balloon application could potentially reduce MACE event and bring the gap between the provisional approach and the DK crush approach far closer, I think, in my view, and reduce the bailout stenting. I think the more stenting to the side branch in provisional approach is driving the results which are suboptimal. Now, obviously, we need a prospective randomized trials. There is a pro-David study which we have designed, and it is being in the discussion stage at the moment and in the pipeline, and probably it's going to throw some light on the role of drug-coated balloon in the setting of complex bifurcation lesions and comparing it with two stents. I will stop here, ladies and gentlemen. It's been a good day so far. It's been a long day, so I'm be happy to have some discussion and a few questions.
Thank you very much, Sudhir. It was a fantastic presentation. In United States, we are very, very excited about the drug-eluting coronary balloons. They are already underway in clinical trials, and we hope that in future they will become commercially available because it's going to fill a very important niche. Any final comments from panel members?
Well, I can do. I think that we still having some limitation in drug-eluting balloons. One of these that, particularly if you are crossing stents with these devices, you might have also loss of coating on the balloon because of friction with the stent. They are not low profile, they are high profile, so it takes, sometimes it's difficult to cross, or you are making some damage on the coating of the balloon. Second, you are losing some coating also through the guiding catheter. That means the time you are proceeding with the balloon to the coronary, you will lose something around 30 to 40% of coating. And this may still limiting the use of the efficacy of drug-eluting balloon. Do you have any comment on that?
There is a question from, we have several questions from the audience, and perhaps maybe I could ask a couple of questions so that we can address some audience questions. Doing kissing balloon after DCB, is the effect of DCB still available?
Yes, I can take that on. I think to the point of Imad, it's a very interesting point that we need, I think we still don't have an optimal drug-coated balloon. We need newer balloons with the good incipient and the delivery of the balloon, how the drug is put on the balloon and how it is eluted from the balloon into the tissue wall and the lesion preparation. Those things come into play. But in terms of if the drug is well applied to the side branch ostium, then I don't think doing a kissing balloon angioplasty will do too much of a disruption. Now, in my practice, what I have done is, obviously it might not be ideal practice, Goran and Imad can say, when I use a drug-coated balloon to the side branch, because I use it after the stent, I use the drug-coated balloon as one of the kissing balloon in the side branch and take a non-compliant balloon into the main vessel. So it's like a non-compliant and a semi-compliant balloon, which does, because to prevent too much of crossing into the side through the stent strut. And obviously, the alternative approach which we are proposing as well in the trial is, if the side branch is diseased, we do the side branch preparation before putting the main vessel stent and do the drug-coated balloon, and then put the main vessel stent, followed by recrossing kissing balloon and repot. So either of the sequence could be done, but my sometimes concern is, when you put the main vessel stent, there is a plaque shift into the side branch. Now, it is very difficult to know whether it is just a carina shift or a plaque shift. So I feel more comfortable doing it after I have put the stent, because then I avoid putting the drug-coated balloon in many cases. So I just put it in where there is significant stenosis. I know what Goran and Vlad think about this interesting technology. I think we need some bigger randomized trial with these technology to see where it fits in.
Yeah, another question from the audience is it important to perform kissing balloon after stenting main branch and a drug-coated balloon of the side branch has already been done?
Well, it's an interesting question. If you cross a stent with a balloon and do a dilatation into the side branch, I think the kissing balloon becomes kind of mandatory at that point, because it forms the deformation of the stent. But sometimes you can do like as people do, is a side kiss, and repot might overcome those things if you don't do a kissing balloon. But in my view, I think the kissing balloon is mandatory if you cross the side branch with the balloon.
I would agree. I think if you're not touching the side branch, and that's already been answered on the chat, there's no mandate to actually do a kissing balloon inflation, but I would agree that once you've dilated the ostium of the side branch, a kiss should be done.
Mm-hmm. Yes.
Goran, can you hear me? You have to unmute yourself.
Yes.
Yes.
Yes. No, I fully agree, and I read the comments of your David study, and I fully support. We should really develop study to answer. We will not know the answer before the study really clearly gives, and I fully agree that kissing should be mandatory.
I guess the other comment is about your practice about kissing with the drug-eluting balloon, which is a very non-compliant balloon. I don't have an issue with that. I don't think there's an imperative that you have to do all kisses with non-compliant balloons. I think it's about the pressure you use. And if you have a well-prepared vessel, you don't have to go to high pressures. I never do kisses with high pressures.
Yeah, that's a good comment. And the other comment which Imad mentioned about, so what I do when I do after the main vessel stenting, usually I first cross into the side branch with a standard balloon, compliant balloon, small balloon, and then make sure that I have dilated that side branch strut before delivering the drug-coated balloon, because I would not suggest putting the drug-eluting balloon directly after putting the stent in the main branch to cross with the drug-coated balloon, because first it will not cross, and definitely it will get the drug will be the balloon drug will be taken off from the balloon. So I dilated with a balloon, at least 2 millimeter balloon before, and easily, and then I crossed, and I never had any problem in my limited experience.
Well, with that, I want to thank everyone, especially all the faculty who has taken a very valuable time out of their very busy schedule on the weekend to be with us as a part of the combined session of C3 and European Bifurcation Club. The C3 virtual program this year is continuing to break records. Today, we have already broke the record for last Saturday. We have over 1,500 live viewers today. So thanks and congratulations to all the speakers for your wonderful presentations. And thank you all the attendees who has stuck around to listen to these great talks. So with that, I conclude this session. You all have a wonderful evening in your parts of the world, wherever everybody is. I know there's a huge number of attendees today from Asia. I know it's a late evening there. So I wish you all good night. And thanks again, everyone, until I see everybody next time in a week or so. Thank you again.
Thank you.
Everyone.
Thank you, everybody.
Bye.
Stay safe. Thank you.
Thank you very much.
Keep safe.